Wasn't too interesting. I said yes.
Oh,
Oh, what makes it interesting? So it's interesting. So I have a lot of things.
I mean, that's like it.
Oh, no. That's a special delivery. Hey. I'm wondering when my worship inspection.
Oh, really?
Did blow my, I had the dresser. Look at that. How's it?
I don't know if it ever considered. Oh, it is, I just, let's say something. Yeah. You just. Erica. Why? Oh, I didn't even catch that. Oh, but look at my time.
All right, it is 5 o'clock. So let's go ahead and call this meeting of the Kittitas County Public Hospital District #1 for July 23rd, 2026 to order. First off, Daniel, you're online. We have a fan running here. I just want to know if people online can hear us okay, or if we need to turn off the fan. Daniel, do you have an opinion on that? No.
Maybe they can't hear.
Sorry, Daniel, threw you a curveball early in the meeting here.
I'm sorry. I realized my volume was turned all the way down, so I didn't catch that.
We had a fan running here because it's pretty hot, but I wanted to know if people online could still hear us with the fan running. It's
Well,
off
I can hear you
so the
now.
experiment is diluted.
I can't hear it at all.
Okay, turn on for a second, Jeff. Let's one more quick check.
She's on it. She can.
She can hear good. Okay, good. So now the fan is on. Can you hear us okay?
I can hear you great.
Excellent. All right, we'll come back to you shortly. Thank you. All right, so we have an agenda before us. If there's any suggested changes, I would entertain those. Otherwise, I'll entertain a motion when ready. We'll to approve. Motion.
Second.
Second. Motion by Matt, second by Erica. Any further discussion? All in favor, say aye.
Aye.
I too will vote aye. Anyone opposed? That motion passes. Consent agenda. If you got a chance to review the consent agenda, I would entertain a motion when ready. Motion by Erica, second by Bob. Any further discussion? Hearing none, all in favor, say aye.
Aye.
I too will vote aye. That motion passes. So now we're to public comment and announcements. If anyone here would like to make a public comment.
I was just wanting to, real quick before we do that, just wanted to introduce Janelle Harding. So she's our new chief of HR. So in addition to the executive team, she's been with us since July 6th now and been making our way around touring the hospital, meeting with employees and giving all the advances and services. So it's been great and excited about the team.
Welcome.
So nice to meet all of you.
Excellent. All right, so that was our first public comment. Is there any additional public comments? Anyone online like to make a comment? Hearing and seeing none, we will move on to presentations. So Daniel, from DZA and Associates, welcome. You have a report for us, I believe.
Yes, thank you. And thanks for having me here. And yes, I'd just like to go over the results of the 2025 audit. So I have a few reports to share. I'll go ahead and share my screen and hopefully it's visible to everybody there. Let me get this set up. And so the reports that I have to go over is the 2025 auditor's report on the financial statements, look at a few key points in the financial statements themselves, a couple financial indicators, a few graphs to share with you. And then the final item is the board communication letter, which contains some additional disclosures from us as the auditors to the board. So starting with the auditor's report, and I'll zoom in a bit to make that a bit more visible. For 2025, we issued an unmodified or unqualified opinion on the financial statements. This just states that, in our opinion, the financial statements present fairly in all material respects the financial position of the district. This is the highest degree of assurance that we can provide as auditors. It's the exact result that you want out of your financial audit. And this would be identical to opinions issued on prior year's financial statements as well. The rest of the auditor's report contains some fairly standardized disclosures. It explains how we came up with that opinion. It goes over the responsibilities of management for the financial statements, our responsibilities as auditors. Again, very standardized disclosures and paragraphs, but it does help to add a bit more context to our opinion. After the auditor's report, you'll see that the first financial statement is the statement of net position or your balance sheet. And on the asset side of the balance sheet, I think the biggest changes that you'll see in 2025 compared to 2024 are really on that depreciable capital assets and non-depreciable capital assets lines, as construction was ongoing in 24 for surgical expansions, and that was placed in service in 25. You'll see those kind of shift between depreciable and non-depreciable capital assets. Otherwise, as far as the balance sheet is concerned, things are very comparable year over year. And then we have the liability side of the balance sheet. Again, not really any significant changes here. Some shifts in liabilities. I'm sorry, was that a comment or a question?
Nope.
Okay. Just got to make sure it's easy to miss once I get going. When you look at the liability side, I think the biggest changes you'll see are just timing of accounts payable and different accruals. Otherwise, very comparable. On the income statement, looking at the operating results, you'll see positive operating income in 2025, 5.4 million compared to about 6.3 million in 2024. So a bit of a decrease year over year, but still in a very healthy range. This is something that I would point out as, of course, a very healthy indicator for the hospital. Is many of the facilities that we work with and in surrounding regions, they struggle to even break even at the operating level and rely on things like tax levies and contributions and grants to show a positive bottom line. So the fact that you're able to generate this positive operating income is, again, a very healthy indicator. The non-operating revenues, this is mostly coming from investment returns and interest. Again, taxes are fairly minimal, so most of your net income, your change in net position line down here, 7.5 million in 2025, 7.2 in 24. The vast majority of that is coming from your operations. So you're not having to be bailed out by non-operating revenues. After the income statement, you'll see the statement of cash flows. And what this does essentially is it takes the changes in your balance sheet items and your income statement items and converts it to cash flowing in and out of the facility. So any significant changes you see on this statement can normally be explained by looking at changes on the balance sheet or income statement. But I did want to highlight net cash from operating activities in 2025 is a very healthy $13.4 million. After the statement of cash flows, you'll see the note disclosures to the financial statements. So these notes serve a couple of different purposes. Note 1 explains who you are as a reporting entity and then goes into some detail on your significant accounting policies. So as you're looking through the financial statements, if there's a line item and you're wondering how that item is calculated or what is included in a balance, Note 1B is a pretty good starting point to get a high-level overview of what might be included there. And then the rest of the notes add even more context for significant policies and significant transactions. These note disclosures are going to be very similar from year to year, unless there's any major changes, which there were not in 2025. So these should look pretty comparable to what you've seen in the past. The one note that I like to point out is note 8 on page 21 of your financial statements. this shows, let's scroll down a little bit more. This shows the breakout of your net patient service revenue line by major payer category. So of course, your Medicare, Medicaid, other third-party payers is going to be your commercial payers, and really essentially anybody that doesn't fit in Medicare, Medicaid, or the patient's line. Supplemental payments is the Washington State Safety Net Assessment Program funds coming in, and then of course deductions for charity care and uncollectible accounts write-offs. So what I want to point out on this table is the other third-party payers line, your commercial payers. These are the real money makers for a hospital. Medicare and Medicaid, at the very best scenario, these are going to be break-even payers. And the more efficient a facility gets, because Medicare and Medicaid reimburse based on cost, the more efficient that you become, the better that a facility gets at controlling its costs. Typically, the less reimbursement it receives from Medicare because of how that calculation all plays out. So the point is, this other third party.
Daniel, we have a question now.
Yes.
When you look at charity care, about 30% increase year over year, are you seeing the same thing in other hospitals or trends statewide?
Yeah, this is pretty similar to what we've seen at other facilities. I'd also point out that charity care did increase, but your total net patient revenue increased as well. So it's still proportional to your net patient revenue overall.
So our net patient revenue went up 30%?
The percentage, if you were to take charity care as a percentage of your net patient service revenue, I believe you'd come up with something very similar year over year. Does that help? Does that answer the question?
Sure.
Okay.
We're going to double check that, but go ahead.
Please do. Yes, so it's the third-party payers that really makes the difference in terms of profitability. The rest of the footnote disclosures, again, are going to be very comparable to what you've seen in the past. I do recommend reading through them once or twice over the years, just to be familiar with what is contained in them and what is being disclosed, but fairly standardized. At the end of the financial statements, you'll see another independent auditor's report, and this is covering compliance and internal control. It's required reporting under government auditing standards. What this report does is explains what we would consider to be, if we had found any, what we would consider to be a material weakness finding or a significant deficiency finding. Since there were no findings for 2025, this report essentially just says as much, so that if we had found something, this is what the definition would be, but there were none identified for 2025. Any other questions about financial statements or note disclosures?
Nope, that's it for that. Anything else you got for us?
Couple of financial indicators, and then a letter, and I'll be quick. So I just wanted to share a couple of graphs, really just 3 graphs that help highlight the performance of the hospital year over year and compared to benchmarks. So the first one is your total margin, total net income divided by total revenues. You can see a very healthy 4.7% in 25, well above what all Washington hospitals are seeing on average and comparable to prior years. The operating margin is showing your operating results from operations, so operating income divided by total operating revenues at 3.5% in 2025. Again, this is where, like I mentioned, many facilities are struggling to maintain a break-even level, so this is a very healthy indicator. And the last graph that I had to share is the days cash on hand calculation. So this is, of course, a measure of liquidity. if at December 31, 25, you can only pay for your expenses using the cash on hand, you'd be able to do so for about 164 days. This is well above what we see in all Washington hospitals in general. And typically we recommend facilities work towards about 120 to 160 days, and then the higher you get, the better. So this is, as a critical access facility in a rural area, this is a very, very positive sign.
Daniel, I know that we saw you at the WISHA meeting, and you probably heard that number too, that there are several hospitals in Washington State that have like less than 25 days cash on hand, and some that have a few that have less than 10 or something. Anyway, it's just it's pretty mind-blowing how many hospitals are really financially in trouble, but also relative to that, how well we're doing with this as a sort of measure of that.
Yeah, absolutely. This is well above what I see at several other facilities. And I mean, this 76 number, that's on average. So you have to consider, for one, you guys are dragging that number up and others are pulling it down. But like you mentioned, well above what I see at other places.
Thank you.
The last item that I have for you is the board communication letter. And this is just some additional disclosures from us as auditors to the board. This explains that there were no changes in accounting policies or practices during the year. It describes what your significant accounting estimates are, and then goes on to explain where there was no difficulties in performing the audit. The audit went smoothly, start to finish. Management's great to work with as always. No audit findings or issues. And then at the end of the letter, you'll see these numbered items that we say we've identified for specific audit attention. This is just what we design our audit procedures to address. So when you see something like management override of controls, that's just something that we're required to consider for any audit as we work through our procedures. Patient accounts receivable, third-party payer settlements, those are complex numbers with complex calculations and lots of moving parts. So we really focus on those during our audit. That is all that I have. Are there any questions for me?
Doesn't look like it.
All right. Well, thank you for your time, and I appreciate you having me.
Thanks, Daniel. Appreciate it. Have a good night.
Thank you.
You too. Thank you.
Next up, we're moving to Department Spotlight, the Verge system and process. Oh,
We need a motion to.
that's why you have the double asterisks there. Good, you passed. So we presented the audits. I will entertain a motion to accept that audit if and when someone's so inclined.
Accept the audit.
Motion by Erica,
Second.
second by Matt. Any further discussion? All in favor, say aye.
Aye.
I too vote aye. That motion passed. Thank you, Mandy. So now we are on to Department Spotlight, the Verge system and process. I think that's going to be Brandy.
It's both of us, actually.
Okay.
Brandy and Mandy, the two E's. And really, I think the better title probably is about our patient safety reporting culture and some improvement we've done this year. So we don't have a PowerPoint or anything, but this is Brandy Coates. She's our quality improvement coordinator. So what we want to talk about is, it is Verge, is what it's called internally. It's the name of the system that we use, but we want to talk about more than just that. So we started looking at our trends in our incident reporting, our patient safety systems last year, which we do each year. That's part of what we do all the time, is on the QI dashboard, is looking at trends in patient safety reporting. We saw that there was an increasing number of reports, and this is kind of happening over time, that were not necessarily patient safety events. So examples of this would be employee behavior concerns that wasn't related to patient safety, or even housekeeping frustrations, or IT help desk ticket issues, or just other operational concerns that didn't represent a safety issue, either to patients or staff or the organization. So this, you might say, like, well, that's great, right? And it is. It's good news that people feel safe in reporting things, and if they had a system that they trusted, and felt comfortable looking up. But we also looked at it as an opportunity to make sure staff understood the systems we have and were they using all of our systems. We have more than just the electronic incident reporting system. And so we decided to have some more clarity about what belongs in Verge, as people call it, what belongs on safe boards, which is another part of our system, what should go to your supervisor or goes in a help desk ticket as another route. So this part of the reason that we care about things going in the right place is that if things are being put in the incident reporting system that don't necessarily belong there or aren't a true safety concern, we can get kind of flooded with excess information, and it can kind of dilute our ability to see actual risk or harm that's happening to patients. And it can divert attention away from patient safety. And also it may not get the proper process that it needs to go through to get attention that it needs. So we want to make sure that what's getting recorded in Verge and on our safe boards is helping us identify risks and trends and preventing harm, identifying system issues that we can learn from, and making sure our culture feels safe to read. So I'm going to let Brandy talk about kind of what we did. What did we do?
Yes, so what we started doing is attending a lot of huddle staff meetings. And just providing more education on what about the tools that we have available to us. So have our work system, which is our electronic patient safety reporting system, but we also have safe boards in all the departments and all over the organization. Safe boards, they like this. So these are posted all over the organization, and really they're a communication tools that departments can use internally when they identify problems. We use them a lot in our department for really like building issues. That's what ends up happening with those. So parking, grass flooding the building, like, or the water flooding the grass around the building, so that's what we end up using them for in our department. But there's lots of things that people see every single day that they need to tell somebody about, but it's not necessarily a harm event or a near harm event that must go into our electronic reporting system. So the safe boards should be reviewed daily in departments by leaders and by members of those teams. And then the problems are addressed internally. They may be escalated to our patient safety system. There's collaboration that can happen among the departments together to try to problem solve these things. And it's really empowering the staff in those departments to take on those issues that we don't have to touch in quality, right? Like they can speak up on those and take care of those themselves and within the teams.
One thing I want to say about safe boards is we've had these in KVH for over 10 years. That came out of an improvement workshop 10 years ago with a multidisciplinary team that said, even if we get a perfect incident reporting system, it isn't visible to the whole team and we can't share and talk about things openly when it's electronic. And of course, we need to put things in an electronic system that are actual harm, but are there things that we can work on a team or just communicate with? And that's one of the things we have seen in incident reporting is so-and-so did these wrong. Okay, did you talk to them about it? Did you, like someone making a simple mistake or not understanding a process? And if we have a way that we are communicating as a team, that's going to be more quickly addressed in the moment. And there might be other people that are struggling with it that it's harder to see when it's in this electronic system. So the SAFE actually stands for Share, Analyze, Fix, and Empower. And that team came up with that acronym because that's really the intent, is that where the team is working on things together and making it's transparent. Sorry, I'm jumping.
When things are escalated into the electronic patient safety reporting system, so the things that must go in there are patient records. And that can also include like staff farm or organization farm. Those items must be reported electronically. I will never not tell somebody to put something in this because I'd much rather know about it and be able to follow up and address those things than somebody feeling like they can't speak up and report something. But once we get those, there's kind of a whole workflow that starts and starts happening once they click save. So those go out to designated reviewers in all areas of the organization. Its expectation is that that's part of people's daily work, is that they are logging into that system and reviewing those open cases that they have and deciding what they need to do to put that. They may also go to particular teams. So all of our medication events, regardless of where they happen in the organization, they go to the pharmacy team for a pharmacy review. Things like blood cases, DVT cases, those all go to our quality RN. That's Bonnie Gibson for her review. So there's lots of other reviews that happen. And then we also will escalate them to physician reviews if there's provider care concerns. That way they can be addressed that. Once we get all of that feedback, really the incident investigation process is really reviewing what the problem was, following up, figuring out what they need to do about it, going and doing those things, and then coming back and documenting within the system. My role is to review all of from the start, get those out to all the people they need to go to. And then once I get all that feedback, is making sure it's sufficient. If they have not addressed the issues outlined in the report enough, I send that back out for additional review, make phone calls and say, hey, I need more. This is something that when D&D comes, they look at our investigations and they if we've done a good job. So that's where I come in. So I do follow up with our leaders when needed if I'm not getting a good enough response on cases. So
You also support the leaders.
and I do also support them in that work as well.
Understanding
So,
how to.
I do a lot of one-on-ones with our leaders in the organization if they need help getting through that work. Some of these cases, especially the really complex ones, they take time. And this is important. And every single person in this organization's responsibility to report. And so sometimes it is a lot. And so I have multiple one-on-ones with our leaders in the organization that choose to do that. Where it's just designated for this work, so that work can be timely and
You get about how many incident reports do we get today?
the number is either 2.4 or 3.3 right now. So I collect data every single day about how many open reports we have, how many new, how many we're getting closed, how many items are in our queue, and then are greater than 30, 60, and 90 days. So we do those, and so 0.3 is our average move per day. Yeah.
And you can see, so you can see in the QI report, so on page 18, it's on the dashboard to you every month, what our incident reporting is, and that includes FERJ reporting and safe board reporting. So they're both on there. That's on the bottom middle graph there. The blue line is the total reporting, and the yellow line is FERJ reports, and the red line is safe board reports. And one of the things that we're really excited about is through all this work, this is a great month for us to come here. We're not seeing a decrease in reporting. So it means that our communications with staff it's really working to go out and talk with people about where to report. We're seeing an increase in safe board reporting. So I think there are some places over time where safe board disappeared or someone didn't follow up on that practice and really understanding the purpose and how we can use them every day. So you can see it's increased. And then in the top right up there, there's the reports of incidents with harm in the month of May. Even though we had higher than average reporting for the month of May, we had 0 reports of harm, where patients needed additional care to ensure that they weren't harmed. So it's working. What we're doing is exactly what we want to see. People are still feeling safe to report. We're able to learn events. They're working on things as teams. And we are seeing a difference in the type of reporting in coverage as well, that it is their actual safety, staff safety, patient safety events. Go ahead.
When I first started on the board, I remember being taken a little bit aback. I think it was the care and fitness report when I first saw the indicator. We want to see those go up. And then I felt so strongly like, yes, we do. We want people to feel empowered to bring those concerns forward. Patients and staff alike. And then that goes hand in hand with the employee incident reports. Not that we want incidents, but if they're happening, we definitely want to know them.
Or there's a risk that something happens. either.
Right.
Sure, yeah.
So I just always appreciate that.
It is a little bit
I like that.
different mindset. And yeah, I remember meeting with like, each of you when you started. It's kind of different to think about. And I just want to reiterate too, that it was never we wanted to make sure that people felt safe. Clearly they felt safe with our incident reporting system because they're putting everything there. So it wasn't to say stop reporting or discourage reporting, but how can we make sure that people are getting things taken care of where they need
The
to.
most efficient, the best place for them to go.
Just so I'm clear about the safe reporting, because so I understand what the acronym means, and I understand that it's different from the Verge, which is safety events, harm to patients or staff. And you gave a couple of examples of what would be reported in the safe system. So stuff that goes in the safe system, just stuff that does not involve safety, harm.
No, it can be near misses. It could be things that are annoying, that are inefficient, that one of the stories that I like the best is the imaging department having this issue where they were calling them because they needed to come do an urgent CT on their cell phones. And the other departments were getting irritated that they weren't answering the phone. And they were saying, well, we're not getting a call. It's dropping off. And the way the safe board works is you just write it on a sticky note. And then when it happens, and then whatever it is. And then if you do something about it, you put a sticky note on top. And that's a visual cue, right? Like if I've got 2 sticky notes, I can clearly see something's already happened. So there's nothing urgent that needs to be addressed right now. That wouldn't be how you would handle an urgent issue anyway. But, and then we're going to talk about it in our huddle the next day. And then if it's something that's like, yeah, that happened to me yesterday. Okay, maybe this is an ongoing problem and we need to monitor it. And so we're going to move that sticky note into this side, the ongoing side. This is for whatever's happening today or this week. I'm going to move it over. And the imaging department used this side to start, they just stuck a sticky note up there every time that was happening. And they used that to then drive process improvement in the department. And they had data, right? This is how often this is happening. And they worked with IT. That were, I don't know the correct terms, but they got boosters for the cell phones. And that still didn't solve the problem. And they were monitoring it there until eventually we changed carriers over that. But that was a way the team could see it together and talk about it together and decide what to do together.
What the yellow and the green?
So this says no harm. This says potential harm. And then this red band says harm, enter into Verge electronic.
Okay, so if you're in the red zone, you're not using the safe board.
You could
You
put
can
something
put-
on here.
definitely also put-
You could use both, but it must go in Verge. And so that's a way to talk and brainstorm. I'm trying to think of other samples off the top of my head. I mean, we get plenty of them, right? We can see it here. What was our last one? Oh, we had a pop-up with the Zoom that was transcribing automatically again, which I put a help desk ticket in, which I should do, right? I shouldn't just, but I wanted to monitor that as a team. We noticed that there's times when that's not appropriate. When it's a protected meeting, you don't want to have it transcribed by AI. So we were concerned about that. We have that on our safe board. I put in the help desk ticket and it's being worked on, but we don't know the resolution yet. So we've left it on our safe board to keep checking on as a team.
At what point do the stickies come down? Whenever When
But it's done.
resolved.
Yeah. And some people had a hard time with like, I can't, it has to go somewhere, right? I can't. And we do a tick mark. That's how we know how many are here. People report each month. A tick mark when they put it on the board, how many safe board stickies have happened through the month, but you can throw them away, right? And they shouldn't have patient information on them.
They shouldn't be hidden.
Should, no,
Like they should be out so that see them, no problem accessing them, and so have night shift come in. Somebody puts something on the sticky sleep board during the day, they're able to see that when they come in. So it can go forward through different shifts and stuff too.
And then also potentially serve as a heads up that this is maybe a friction point that they might encounter in some workarounds.
Yeah. And some departments have, this is a size that we take to show other departments. A lot of people have a big size, a flip chart size. I know some departments like IT has a virtual every day and they have a virtual safe board that they use. We have a virtual safe board that we started using with our safety briefs this year, which has been great. I think it's really helped escalate some issues we need to know about organizationally. So it's very similar to this. It's just a line and we keep it there and keep monitoring it till it comes off.
So so the safe reporting stuff is handled at the department level. And so what do you guys get in quality? You just get a number from
Yep.
each department?
Yep, of what type. So we hear whether they were green, yellow, or red.
We don't get the content, those, and there are items that end up in both places. Because sometimes people will come across an issue and then they put it on their safe board, and then once they have a conversation, they're like, wait a minute, this actually needs to go in Verge, this actually, so some items do end up in both places because through the process of those conversations and collaboration within the teams, they make a decision point of like, this actually does need to be escalated.
Or it's cross-departmental and we need more help and we're gonna be able to better manage this in incident reporting system where multiple departments can touch it and report on it.
Then there would also be a kind of reporting that would, I suppose, not fall under either, that would be like HR issues or something.
There's
Like you're not gonna, you wouldn't stick up there like Eric is bothering yours. All right.
No, but that is what we were seeing in Verge. And so what happens when we get that, right, is we send it on to HR and all we document in incident reporting system, which is a protected quality improvement patient safety system, is that we have forwarded that to HR and the manager.
But that doesn't now, that shouldn't go in Verge or safe reporting, right? That's HR.
And sometimes what we see is that people will do that. They feel like they've escalated things and not been heard. And sometimes it's because they don't feel safe, or other times it's because they didn't like the answer they got. They're putting it in the book.
Yeah.
Okay.
So if a staff member wanted something to be confidential. All department or something like that. They go straight to HR.
It's,
Have like
are you talking about a safety issue?
like a patient says something to a staff member, or a staff member says something to a patient that's inappropriate or.
So our electronic reporting system does allow all of our staff to report anonymously.
Okay.
It truly is anonymous. I imagine I could get with Jeff and track down an IP address or something like that, but I've never felt compelled to ever need to do that. But it truly is anonymous unless the reporter writes their name in it somewhere identifying as a reporter. When staff choose to utilize their email, so all of our staff, when they come to KVH, they are provided with a Verge account. They put in their KVH email address, and every report that they enter when they utilize their email is attached to their account. They're actually able to log back in later and review the cases that they entered, and they don't have full access to all of the, we can call them pages of the investigation, but what they have security privileges to be able to access, they can. I always encourage staff if there is, for some reason, they don't feel safe putting their name on something, which I want them to always feel safe doing that. I always tell them to reach out. And they do, they will email me, they will call me and they will say, hey, I just want to let you know, I'm the one that just put this report on, in, but I didn't want to put my name on it for whatever reason. And but they will ask, can you please keep me updated? So I just put a pin in that and I make sure to follow up with them and just really as much as I possibly can respect their request to have that information. Now, on the other side of that, we really do want to know who our reporters are because we want to include them in our investigations. We may have more questions, we need more details. They might have ideas about how to fix whatever problem they're reporting, but we can't do that if we don't know who they. Also, a lot of the feedback we got on our survey of patient safety was that we put these reports in, but we don't ever know what happens to them. We can't follow up with our reporters if we don't know who they are. So we just have really been encouraging people to put their name on these reports so that we can include them. We can give them feedback as appropriate through all of the investigation process and have the leaders for those areas follow up with their reporters as well. Yes, it can be confidential.
And there are, so Jason and I have access and Brandy to everything that's in Verge. And so one of the things we talk about when we go out with people is if you have a concern about your leader, you can put in admin as the department or HR as the department or quality as the department because they're automatically routed to the leader of the department that they enter. So that's one of the things we talk about is if you have certain people you don't want to see this is how you can report it besides the anonymous. And then if they don't want Jason or I to see it, they can report it to the compliance officer who has a whole separate.
Or if a patient had a complaint, is that who?
That's to Tony Clayton, who's on actually our patient experience coordinator, and it is within Verge, but it's a whole separate process. So there's a link on our website to report concerns or compliments, and that's this other data on here, the care and service reports on page 18, the top of it. So it is managed in Verge, but it's a completely different workflow.
And I don't do those.
Not anymore. Jeez.
I used to do that, but no, that's
Tony
like
Clayton.
therapist.
Same process though, in that they must be investigated. That's per CMS conditions of participation. And we have to follow up in writing with the patient. And so they get routed to the different leaders who need to investigate it and respond. And she doesn't respond to the patient until we have adequate response. Way more questions than you thought.
Yeah, I'm just like trying to judge. So if a patient wanted to report facility issue or like someone made a comment to them, would the patient?
The patient would contact Tony Clayton, the quality department through the care and service process. And so that's through calling us on the phone. There's like I said, an electronic request, piece of paper, however they want to contact us.
So that Tony, once they look through all that stuff, that department would contact the patient. This is how it's.
She doesn't know. We have to respond in writing once it's a grievance through, and so Tony writes all those responses because there's certain elements that are required by CMS conditions of participation. And we don't want to put that on 20 different leaders to know how to do that correctly. And we have time frames we have to meet as far as our response. Another thing that DMV looks at and reserve. That was it.
Thank you both. Appreciate it. All right, so that includes the spotlight presentation. So we're gonna move on to reports and dashboards. First up is quality. Mandy.
Yes, back again. My reports start on page 12 and I am sorry, I don't really have anything to add, so I'll take questions.
Looking at the,
Oh, which
missing briefs that that measles is creeping closer again.
I just heard this morning in Huddle that measles is in Yakima Memorial in their OB. That's not good.
Also over in King County. I don't know if it's the same person, if they went from here to there or.
I don't. Anna would really appreciate that you notice vehicle, because I think she feels like she's always chicken little like. But there is not a lot of reporting about it, but what she knows from calls with the state is there are numbers of people being monitored within the United States. And so through this whole process of revamping our Ebola, and we're finding we have supplies that we need to resupply that, it was almost 10 years ago, I think, when we had to create this whole Ebola response to begin with. Making sure we have waste management contracts in place. So there's a lot of good work happening now when it's not an issue, and hopefully it never is an issue, but.
It's good to be in it.
I have a question. On your summary of improvement opportunities, the third one down is surgical first case on time start. What is happening? Why is that so challenging to start surgery on?
This measure looks at, was the case started within 5 minutes, 7:30 a.m. I don't know the answer to that, why that is different. I know that there's been
Patient showing up late, not coming into the room on time. Be prepared to start the case within 5 minutes of on the patient.
a very narrow measure.
Starts at 6 minutes after big news.
Yeah.
Time.
Also, if
6
it
minutes
starts
is
a
the
half
same as an
hour.
hour as far as this.
I doubt they all start at 6.
And there are measures that we can look at that look at the on-time start delta, that looks at the difference between, you can see to kind of, it's starting on time, and Dr. Benoyer is very timely.
And this is just surgeries or stones and
Just surgery.
surgeries.
Want to give a name of someone who's not?
Oh, not one of them.
But it's measured, so there must be a reason it's measured.
Because they're working.
Yeah. Tell them the board encourages them to start on time. The patients, if the patients show up.
We'll
Fix
pass
it.
that on.
Yeah.
Mention Bob's name specifically.
All right. Yeah.
So,
Yes.
all right, anything else for Mandy or you for us?
No, just, but I know you've enjoyed Gembaing, and I think it'd be great to Gemba with Amy Krugstad and Holly Simmons and talk with them.
Yeah.
I think they would love to talk more about it and show you what they're working on. I know they've been doing a lot of work around this. It's just I think it's gonna take a little bit of time. And I think even Dr. Benoyer with his block utilization committee, there's several things happening that they're
She says Holly, it's not me, it's the audio video.
Yeah,
Holly
okay.
Sessions.
I will not pester you with that.
Yeah, thank
Okay. Yeah, well, I would personally enjoy that. Love to kind of see how the operation works. No pun intended, sorry. Yeah.
Catch that.
All right, thank you, Mandy.
Yeah.
So moving on, welcome Janelle.
Thank you.
HR. So you've had a couple of weeks to get settled.
I have.
Anything you'd like to share with us in your report?
So my report starts on page 19. Probably the big highlight for my department this month was the experience healthcare that we held for the high school students. There was a lot of participation throughout the hospital and the community. A lot of work and effort went into it. So very, very proud of my team and everyone else who participated. I am currently really learning about our department. the hospital and thrilled to be here and to learn more.
How many people participated in that event? I mean, students?
There were,
Approximately.
I think there were approximately 12 adults.
And that's seat limited, I believe, isn't it? They cap it.
Yes, and they have activities every day,
Pretty busy,
all
yeah.
throughout the day, and they go to our clinics, so a lot of coordination and effort from community partners, so it's a great experience.
One of the things, I don't know if John's gonna talk about this later, but one of the things that they really talked about a lot at the AHA meeting that was at was getting to people early and talking to them about the sort of employment opportunities. There are a lot of people who are kind of intimidated by the hospital. A lot of people think there are two jobs you can get there, either nurse or doctor. And they don't realize all the different employment opportunities they have. And a sort of theme on a lot of the sessions I attended were get them early, talk about all, and give them a lot of different pipelines to get into the organization. So good we're doing that. Yeah, the more the merrier.
If we need to do for.
Yes, they come and they do a lot of their rotations. We go out when the schools have career fairs. We talk to them, and so different HR team members have different affiliations with local schools. I know just in a couple of weeks I've been here, we've really been talking about what can we do to maybe get in front of some of these students that are not on a health career track. And really partner with maybe some of the high schools, middle schools to get out in front of kids that are a little more at risk. That could, maybe they aren't going to go to college, but there are other careers within healthcare that don't require that type of education. But they are still very, very needed and important team members. So I'm really excited to see what we can come up with over the next few months and really give to our community. I mean, there some pictures also for you, Jen. But really beautiful. Yes, super cool. It's fun. I know he spends about 9 months pulling it all together. It's a lot of.
Central,
Observations, it get a little more complicated. We have to have affiliation agreements because there's privacy and insurance. But a lot of the schools we do have agreements with. And so if you know someone who's very interested, you can contact my department. Kyle works with a lot of our schools and we can see what options we have available.
A lot of requirements, observation requirements for even seeing on. There's not so many.
Or volunteer backs.
Yeah.
Yeah.
So we. Do that.
We do.
Like that.
Yeah, and we have direct lines with the schools, and so a lot of those opportunities are advertised within the schools.
We would continue as well in the departments of students, especially from central and all the schools. The relations as students right now. IT often as a student. Scott Casey had a student for analytics and numbers just recently, so very common.
Questions for Jim?
Thank you.
Well,
Thank you.
anything else for us?
Thank you so
Appreciate it.
much.
All right, moving on to Chief of IT, Jeff.
My report starts on page 21. Couple things to highlight. We had two projects go live last week. I'll just briefly talk about it because I'm sure that's intended. For urology services go live. And the campus address change went live. So one on the 15th and the other on the 16th. Really the things that we're now anytime in post implementation is really around the billing and the clinical side. And so, once the front end is going, everything went really well with the go live. And so now we're just monitoring the next couple of weeks. Highlight those two. Other things from the Oracle side, we're implementing camera capture. And so currently we are using digital cameras to take photos that we download our DMAs and providers download into the system. And we have an application now, Oracle application that's on your cell phone that they'll be able to directly take photos and have that directly go into the chart. So there's no photographs saved on any devices. It's streamlines the process. And it goes directly into the patient's chart. So I think that we're preparing the next probably 2 weeks. We're doing some testing right now. And we'll get that out there. And then the other is some other functionality around our ambient AI, or we call it CA, so clinical AI assistant. So this is where the providers have their cell phone and it's listening to the conversation between the provider and the patient, putting everything in the chart notes. The next functionality for that is it's being able to listen to any order suggestions that the provider is making to the patient. And it'll start to capture those in at the end of the visit. We'll ask the provider, hey, I heard you say a chest x-ray and a CT. Would you like to order those? Those will automatically into the Oracle video. So physician will not have. It collects an extra time in the system. There is additional more functionality coming out along the way with all of that as well. So we're just trying to do this in empathy. Any other questions?
Do it through like computers or something like kind of weird? I mean,
What's that?
so the interactions that for you? Explain that a little bit more.
Yeah, so we have KVH provided phones that the providers are using. And it's listening to the whole conversation. It's dropping all of that into a note form that goes into the patient's history automatically. So the patient, all the physician does is reviews that.
If the patient didn't want some of that.
They cannot collect that as well.
They do that.
So I think through the examination, there's an option that the physician says, hey, I'm going to be recording this. And do you want this? Do you want to participate in this or not? And if they say no, then it is turned off. Then he or she has to go in and do it the old fashioned.
Yep. You have on here patient portal 2.0 as the near future project. It's a timeline on that.
Yeah, so I'm trying to get a more accurate timeline from Oracle on that. They had initially pushed it out, but they pulled it back because they wanted to add more AI functionality for patients to interact with the portal. And so I think it's in beta right now. And it's probably going out to first few, we call them, kind of the pilots, and then from there, but we don't have that, like this is the date. We are on the list to be signed early, to participate in that. So we are on the kind of the top of the list that goes afterwards. I assume hopefully before the end.
Okay. All right. So yeah, I just was thinking the ballpark that you're talking about.
Yeah.
Months, years. All right. Thank you.
I'd like to pick the brain a little bit about labs. Historically, I've had a slew of labs run each year, and they've usually gone through LabCorp because so many of them were send outs. And so I had my history on LabCorp. Recently I had them done down at the MAC and had a notification that I had like results like it's so fast, which was fantastic. The trade-off though is that there's no pretty graph that I can look at to track my trends over time. Is that something that they might be offering us?
That'll be in the upgrade that people will.
So as a patient, I'll be able to look at my portal and then click on whatever.
Yeah, as long as the results are done, with our lab,
Okay,
then yeah,
and it'll compare.
it'll trend it.
I love that. Okay, that's where
Yeah, right now you can look at it, but it's all,
it's just value.
it's by sequence. Right?
Yes, yeah. Great.
Any other questions?
The bottom of page 22, the security assessment and training, the graphs. Can you just, is this industry wide or is this our particular hospital? If you're able to find.
This is our particular hospital.
And so we dropped down to 1.4% in this last metric. Am I reading that correctly?
Yeah, so industry-wide, I think it says on the right-hand side, there in the fish prone is at 4.4%. And our average right now is around 5. What you do see with the lower, our last campaign, and I think that is kind of a false percentage because it shows a percent even if the phishing test is active. And so it might not have everybody in the system yet, but it's showing kind of where it's at
That moment, but it's not actually conclusive yet.
Right. Yeah, the difference too is we do both phishing, so we do the old classic phishing, and then we do one with AI. And the classic one everybody knows anyway. So that's where you see the 2.2%.
I got an email from KVH at 4 p.m. last Friday that said my password was about to expire unless I clicked on this link. Should I click on the link?
Your choice.
Is it normal to get such an endorphin for that? Congrats, you have identified and waited for that. Feels so good.
Anything else for Jeff? Thank you.
Thank you.
Appreciate it. All right, so moving on to Chief Nursing Officer Holly.
My report's from page 25 and 29. I don't have a lot to add. Any questions about that? I will say we just completed a 4-month charge nurse class for all of our charge nurses. We have discovered that we could do a better job in educating leaders. And so we came up with a program, Clinical Excellence did. 4-month program, charge nurses were required to go in and do some work on the computer, but also attend the class in person, wanted to go through some scenarios. Some of the feedback from that class is that they want to meet, they feel like they have some camaraderie, and also that we need to continue to provide for new charges some education. So we're going to continue. Anyway, very successful, and they were happy. Ellen from our Clinical Excellence program did a fantastic job in putting that together. So I want to really call out her.
And the charge nurses here, is that something you rotate into or in a basis, or you achieve that level? And that's kind of where you stay as a charge nurse?
I've discovered charge nurses are voluntold, some are volunteer. We don't really have a good process for that. Where I've worked in other places, to apply for that. But here we don't really have a good process, so that's something I would.
Talk a little bit on just the space out here. Did you mention this?
Oh, yes, so Jason encouraged us to attend, all my nursing leaders. We attended a symposium in Fort Townsend, Washington. And it was a 2-day symposium that we learned, these for critical access hospitals, leadership. We had a speaker we had several speakers that were very engaging. We had a good time, so all of them came and kind of to bond and
It was amazing.
anything you want to have.
Just wonderful. It's the first time they've done that. Jefferson put it on and it just was so focused on rural nursing leadership. And so just so applicable and really getting at some of the issues that nursing leaders are facing. And it was a wonderful time. We made sure that we had time to be together too. So working as a group is really nice and not just rushing back at 8 p.m. And so it was a really good time for us to collaborate too. It's
Bonded and really have a good time. The other thing Jason wanted me to mention is the remodel for, and I think you have some paperwork here, but Dee Dee's been working hard and working with the staff and JJCA to help us or get their ideas as far as Mona down in ED. So we just had a meeting. What she did is she put up these things and asked the staff their ideas. They would write in things, and he has met with the architects and we've met with Jen and myself. We have a meeting today finalizing some plans, but really tried to involve them in having a say in what their space is going to look like.
And so each page is a phase, or how should we look at?
Yes.
Yeah, so it's a draft of phasing plans so they can do the work without any disruptions to those services and minimal to
And then
and not final, still working what are we?
so still being tweaked, but in theory, then the last page would represent what it looks like when all the phases are done.
There will be an increase in space for patients, which is a good thing. We're going to get that. So anyway, I'm really excited.
And then the other thing that this is tasked with is this is a short-term solution to add a few more rooms and clutter some of the hallway areas and then also make some of our current rooms safer for staff and patients. So having double swing doors so people can't barricade themselves in and their staff in, moving away some of the exam notes are situated in the rooms for safety. And then with it, for other phases to expand the ER, we have to go outside the wall, expand the footprint of the hospital. So trying to design this in a way that would flow right into
Work the way.
so minimal throw away. Yeah. Pursuing similar process with our HC makeup and
We figured in a couple of weeks, we'll kind of start to lock this down and still get some small tweaks.
Yeah.
Actually,
couple more weeks from staff to lock in and then a couple more weeks with the SBA and hopefully we get a rough estimate from the architects and then we'll be. For people to go get.
nice to get to more room down there and streamline some of the processes. So, good.
Any questions for me?
Questions?
Okay.
Thank you.
Yeah.
All right, so moving on, Stacy's not here. Is anybody handling her report tonight?
Yeah, I've got it here.
Chief Operating, handled by Jason.
So Stacy is out for the next few weeks, just out enjoying life and exploring the country a bit. Couple things, just wanted to call out three items here on the report. Imaging. Due to conservation efforts, we've been able to increase our supply for contrast. It's primarily used in CT from 10 days to 30 days. There's a major national shortage of that contrast going on. We can't just order more when there are other shortages. We're on strict allocation, which is based on historical ordering. So our best methods is to use conservation rates. We haven't had to cancel, delay any procedures or anything to impact care. So just trying to be really conservative with those measures. Dr. Thomas might be able to explain a little bit more efforts to that, but this kudos to our medical staff for being very cognizant of that use.
Certainly, alternative tests can offer similar diagnostic capabilities, and so serving those doses of contrast for just the test that absolutely required is how we're achieving it.
In the sense of when you have shortage, well, it's not being a shortage.
No, but our conservation efforts with our allocations, we're doing really well. So it's just an absolute kudos to our team. We've unfortunately, or fortunately, have had good practice at this. A year ago with IV solutions and then a year before that with solutions again. So thankfully, our staff was able to with it pretty quickly and be able to conserve. And then the other one, lab, just wanted to shout out that we had a staff member accept the position of our lab development coordinator. So this is something that Stacy brought to this team to help with onboarding, training, supports to hopefully lower the amount of turnover in these areas. So that position's been filled, and that's something that the clinics have done with their inmate development coordinators, the PSR development coordinators. They saw a significant drop in that turnover rates and a really increase in consistency for this provided. So awesome to see that. And then last but not least, investing in new staff that are entering into the workforce. We're going to start a phlebotomy training program, partnership with Providence. So phlebotomy is an area in the lab that will always have a high turnover. That's just a foot in the door healthcare position. And we encourage them to branch out and go different positions, hopefully within the healthcare setting. So this is an intentional effort from Stacy and Rhonda to help bring in phlebotomists into our system and create that pipeline for other positions. And then we also get I think it's about $4,000 per student to run. But we'll get, it's about 2/3 of that in grant funding to them as well. And then we'll be putting up the balance of the bill. We will pay the staff as well, employees. There will be a temporary through this program. They're not guaranteed a position at the end as well. We're looking to apply for it. That's how we're doing the same rate program as well. Any other questions?
How large do you think the October cohort will be for this program? Like so many slots or?
We talked about those people too.
How long does the program last?
6 weeks. And there's only so many hours during the 6 weeks. It's not 6 weeks of full time.
Under urology, it said that our first patient was scheduled on July 16th.
We have more information about other patients being scheduled.
There was 10 patients the first day on a Thursday, and then there was 10 patients scheduled on that Friday.
Thank you.
I went and rounded on the first day and I took Dr. Chava and the staff. It was awesome to see the clinic open. It was awesome to see KVH urology on the wall, the community relations program, all the signage and stuff there. Yeah, it was really exciting to see.
Urologist seeing a lot of patients.
Yeah. Well, so right now, Dr. Chava is doing 1 week a month with us. And then we will have a full-time PA starting in
It's August rolling start, full-time in late.
Yep, and then, so then we'll have 5 days a week coverage, 4 days a week coverage.
We're presently booking into October for Dr. Chapel, so. A lot of demand.
Build it and they will come.
Oh, yes.
And that's that's been the message we've received from seems like every new,
Then the goal is to have, right now we have 1 OR day a month, so our goal is to get to 1 OR day every week. Really exciting to see that taking off. We've had, urology has provided service here for quite a few years. They did not provide any service for them. Also, everything, whether it's everything. It's really exciting to see this. Everything we hear. Everybody. So many areas of the hospital that use this type system. IT to the OR to the clinics, to medical staff, HR, everything,
All right, anything else for operations? Anything else you want to report for spaces? Nope. Okay. Thank you. Moving on to medical staff, Chief of Staff, Dr. Hoppy.
Yeah, my report starts on page 32. Medical Executive Committee, a very busy You can see, we reviewed a total of 41 credentialing files. Big chunk of them are onboarding new RDocs. So, yeah, a lot of new positions starting in the emergency room. Other than that, I'm happy to answer any questions.
And are we requiring the emergency docs to be board certified going forward, or that's been a transition? Does that impact why this list is bigger, or is it just a coincidence?
No, it's just a coincidence.
Okay.
There's some people, that the demand is hiring more people, but I think, probably safe to say that our whole, teams we need to certify.
Yeah.
It's really raising that bar, the quality bar.
Yeah.
And they're not, and I think that's a really good.
Yeah, definitely.
This Mary Lyons is gonna be the full-time PA in urology.
Any other questions for Dr. Hobby? You have a request for us to approve the credential list.
Yeah.
Okay, so there's a credential file in front of you. If you're so inclined to make a motion, Terry, you're welcome to.
Yeah, I move that we do these 41 people that we're talking about.
Motion to approve the credential file by Terry. Is there a second?
I'll second Julie's.
Any second by Erica. Any further discussion? All in favor, say aye.
Aye.
I too will vote aye. Anyone opposed? That motion passes. Anything else for us, Dr. Hoppy? Okay.
It's a lot of work.
Thank you, Dr.
Yeah.
Hoppy.
What does Shannon do to stay busy during all of her free time? All right, so we move on to Chief Medical Officer, Dr. Thomas.
Thank you very much. My report begins on page 34. I have no amendments to make, but I would second your tentative motion that Medical Staff Services Office deserves recognition for this month and next month's slate of candidates.
Some more coming down the pipeline here. Yeah, again, I'm so impressed by the work they do preparing all those files to be reviewed and yeah, it's a lot.
I need to affect us all.
Yeah, it all starts there. So that's great. Any questions for Dr. Thomas on his report?
Please elaborate on the early seizure identification.
I would love to.
You told us about this previously.
We may have alluded to it. We've been a little bit coy about technologies that are not yet fully ready for prime time.
Less
I'm happy to elaborate on tonight. So this is a product which is FDA approved for the role of assisting an emergency provider in identifying cases of seizure that might be difficult to assess. We've all seen television shows where tonic-clonic seizures have full generalized body movement. Turns out the vast majority of seizures probably don't have that present at all times, and some patients may be in mild states of seizure, may mimic other disease states. So being able to easily differentiate that state from other diseases to the plasma emergency physician to route the patient to the necessary care that they might need at this facility or elsewhere, and rule out some more serious diseases in the process.
Let me tell us kind of maybe how it works.
Maybe how it works. So electroencephalography is the process of measuring the electrical activity of the brain, very much the way that electrocardiography measures the electrical activity of the heart. Using AI-assisted tools, we're able to differentiate between normal electrical activity of the brain, event of consciousness or sleep, from the abnormal electrical activity in the event of a seizure. And so this allows the clinician to get a rapid assessment of seizure activity if it's in fact.
Maybe things are more nuanced or subtle that will pick up very easily, but it can.
Yes. I think that Dr. Hoppy would second my assessment that electroencephalography is a lot more complicated than electrocardiography. And so it is not a skill set that most clinicians have reading these. So the AI assist is an absolutely necessary tool to be able to make this diagnosis.
Yeah, probably the only one that can read would be a board certified neurologist.
Very interesting.
Very excited about it.
Questions for Dr. Thomas? Recruiting of providers. just as challenging as always, and we
Always challenging, but I think that the recruitment team deserves commendations for their efforts in helping us to onboard a number of especially primary care providers coming several months. So it's very exciting progress.
anything else from you to us?
Nothing else to add.
Okay. Thank you for your report. Appreciate it. So we're going to move on to financial services. Jennifer, Chief Financial Officer.
My report starts on page 37. I really don't have any more words to add, except for I think we've all been hearing a lot about the RHTP funds. And it's been a kind of a hurry up and wait while they iron out all the details. Now Wisha has finally signed their contract, and we are wanting to look at boilers for consideration for applying for those funds. That really goes really well with what the criteria are for the Bishop funds, different buckets. And as you know, we have the roof we've been considering, and the boilers we've been needing, and the chiller we've been needing, and just decided that the best, most efficient use of the money would be boilers. Problem is, the boilers cost more than the Wisha funds are. Our first estimate was 2.23 million, and the Wisha funds are 736,000. So what we're asking tonight is, and we brought Trent here, he's going to speak more than me about boilers. If you have a question. But what we're asking the board tonight is for recommendation to move forward on working with going out to bid up to the $2.3 million that we have our first estimate for. We cannot spend the money until we get the okay and the approval of the application for the funds. But it's a jumping through hoops. Sequence of events. So if we could jump to, and then I'll go back to the financials, page 47 of our capital expenditure board narrative that you have had. That's what I know about boilers, and from information from JJCA on the next page, where as part of the master plan, they had engineers come look at all our infrastructure and assess the condition of all of the mechanical pieces of our hospital, and the boilers also were recommended them for replacement. I think that's what I know about boilers, and I'm gonna turn it over to Trent.
Yeah, so any questions that you guys have, but really the state and the condition that we're looking with out there in our boiler industry, we have five been our Airco boilers. I started several years ago. I know Ron had those already identified. This short-term capital plan as needing to be replaced. We never got to that point. They're currently about 26, 27 years of life, so they're definitely at or past that end of operational life cycle or recommended life cycle for those boilers. We've seen it in the last couple of years as we had recurring maintenance come up, and we had annual maintenance with certified boiler mechanics come in. So the feedback we get is a lot of challenges around sourcing parts. So at one point last winter, we had 3 of the 5 boilers down, different part problems. We were able to, we were able to basically pull parts from one boiler, the one in the worst condition, and part things together and get everything back online except that one boiler that we had to really pull parts away from. And then there was an extended lead time on getting the remaining parts for that last boiler. What we're just seeing is an increase, a steady increase of potential problems around those boilers. Every boiler out there has a piece of paper on the front where engineers are documenting, logs, a lot of problem codes that have occurred on the boiler and things like that. And the list just kind of keeps growing on those. So that's what we're looking at there. These boilers were also part of, our energy, the energy improvement, process that went through, with Apollo. And they were identified as an area where we could also generate energy savings and kind of increase our energy compliance for the organization. So Paul has been helping look at, the potential boiler replacements, more high efficiency boiler, some opportunities around the hot water pumps that look after those boilers. They're on variable frequency drives, so we're just basically running 100% all the time, 24 hours a day. Basically, if we put variable frequency drives into that system, they'll throttle up and down with the building demand, they'll have energy savings. So it's all kind of so part of that several years ago with that energy project. So kind of putting all of those pieces together. Well, in this ask. Question?
So just to give the other board members some perspective, we talked about this in the finance committee, and these RHTP funds are tricky because there's only a few things we can use them for. And following rules, for example, I'm told we cannot use it to resurface roof. That doesn't meet the requirements. So the boilers meet this requirement. I think as Trent is saying, they're not at end of life, but they're in a phase where maintenance is a little scary because you can't just grab stuff off the shelf. So it's a tough one to do, but we're running a large institution. It needs to have a good boiler system. And so after a good discussion in finance, we came to the conclusion that this is a good one to forward to the whole board, but that's how we got there. And in essence, we wouldn't move forward until these funds are allocated. So we're getting like a 30 or 35% discount off the price of these boilers through this fund, so to speak.
That's correct. And we have one more board meeting. So for the application. So I guess what we really want is the approval to move forward and really take a look at our bid process with that, how we can.
I think there's work that goes into it. You wanted to know the board was supportive of it to make sure we weren't wasting people's time. So it's, again, it's a big number, but it's an important part of the institution. So
With the application, we would like to have a motion from the board to authorize us to move this project forward. Contingent on receiving those funds, so I think stating that as well. There's another thing with those funds that can't be used for anything that's currently. But can't be used for, oh yes, I think those funds, I think. You finished, the funds can't be used for anything that's currently ongoing, it has to be new.
and by us doing a motion, we don't check that box where it's now put on being
Contingent on this RHTP funding application.
So let's make sure that's
So written there, the balance, yeah.
better.
We're looking for place to use the RHTP fund when the this. And when we would have seen this.
Hopefully before this winter.
The timing
It will
is very.
still be.
I mean, it sounded like that just in this narrative, so. If we don't do it, it could be more expensive. So if we wait for them to break. It's not a good idea. No, it's not a good idea.
And it was probably back to Ron probably would have even brought it by now, which we want with. We've surgery expansion. Just all resources got out with that.
Trade-in value or. Yeah, trade-in value, not so much, but yeah, one of the things I can and get Apollo to introduce. They definitely can produce return on investment numbers. Around the energy savings that we'll see in some of those system changes. It's definitely show that kind of return on our investment.
It's used for the current boilers, what fuel will be used for the new boilers?
Currently natural gas. It would still be the same. It would still be a natural gas fired. We have a backup boiler that we're not touching intentionally. It is gas fired, so not natural gas, regular diesel fired, so that if there was ever a natural gas disruption of the facility, we'd be able to fail them for a time. It's old, but it's a beauty of it. We take care of it when it.
Well, if you don't need it, but. It's
Right.
there for you to, yeah. And it's my understanding that if we move forward, replace the boilers, it's kind of done partial at a time. So you never completely shut it down. You're swapping one of the systems out, getting it up and running, and moving to the next one. So is that accurate?
Correct, yeah, so we came in, they looked at the piping, the current setups there, everything thankfully has been valved and kind of designed to allow us to take one of the old boilers out of sequence, replace it with new, tie it in, bring it operational and phase through replacements, so not anticipating any disruptions or upheavals that way based on the current layout structure.
These provide hot water and heating for the facility?
These are just for the dedicated heating for the facility.
Dedicated heating, okay.
All the heating group basically there to keep the facility.
And that's heating in this one footprint or all around this parking lot, the different buildings?
Just the hospital footprints. All water ones are newer, either actual system that would be written to.
Any other questions for Trent or Jennifer? I have a feeling about this, what they'd like to do. Motion by Erica, second by Matt.
Yeah, I just appreciation. Some walk down there. It's a lot of machinery down there. But expensive. Keep it Matt. Pretty clean.
A lot of redundancy. We have to do 24/7, whether the power goes out or a boiler goes out or all, so much redundancy. Some are the this system. There's 5 of them and they'll have 2 running. They'll switch to a different 2 or 1, 3. So we're never maxing out our boilers currently. Plus 3 of them are down, which happened last year, which gets really scary. So just having all of that redundancy to pumps that pump them through, one runs for a week and then it stops and the other one turns on for a week. So that redundancy back and forth as well. So everything we do, we have a pretty big redundancy need. That's something that we've been working towards over the years and boards have moved this since to get a lot stronger. I know when Jeff started, we looked at our server rooms. There was nothing redundant on those, and I think we officially now have a more redundant server system, and that's already come in. So we had some issues a few months ago, maybe a year ago. Gonna be the last, not the second server system. If we didn't have that done.
Yeah, or just a lot of the intermittent things, right? You never see them anymore, so.
Yeah. So, next year, let's say, likely what we would be looking at is generator systems, redundancy going.
And assuming we're able to move forward with this and the funds come through, what time frame will we have to actually have this happen? When it's
As soon as we have bids in place and we can select a bidder. So if we have to, like I said, that some of that groundwork is done with that energy project, so there's some plans kind of already sitting in place and how that would. So. As soon as we can get a bid.
Can it be done in the dead of winter if it needed to be? Is it?
I mean,
Not ideal probably, but.
over cautious side wants to avoid that, but the fact that we could still phase one at a time, I think we could safely do that. I don't think it's in the middle of winter that gets cold, but there we go.
Then there's a full backup diesel boiler as well if we need it. It's named.
I call it.
So, all right, we have a motion and a second. We've had a discussion. Any further discussion? So all in favor of moving forward with this capital expenditure approval, say aye.
Aye.
Aye. I too will vote aye. That motion passes.
Thank you.
Yes.
For the rest of the capital, back on page 38, there's some updates on Radio Hill as well underway. Starting to build back now, I think starting on the electrical and still on track for a November 7th projected end date. The parking lot will go to bed next week or the week after. Really love for to squeeze that in, but I just don't know how. I just don't know if that's gonna work this year or in the spring.
If we're not able to get the parking lot portion pushed ahead which year, how would we utilize the new 10,000 square feet? Because I would assume we must hit some parking caps before we fill out the entire facility.
Yeah, we were talking, we likely would not move full capacity.
No shuttle buses or anything involved in this?
Yeah.
We have talked about putting temporary parking, and I don't know if the city will let us do that with the gravel. Architects have said, yeah, that would be okay, so we could with that, but I don't. More to come on that, I
Yeah,
just,
take it as we get there.
so probably next month, Holly, you think those folks will come back? The surgery team brought to Capitol a number of scopes, and we sort of said we'd rather see, you build up to the 11 scopes they were asking for over the years, and so they've gone back to the drawing table to see how many they really need. And so we'll be seeing that next month. They've still waiting for urgent care x-ray or urgent care, sorry, gala dollars to be figured, so we know how much we need to go back for that urgent care x-ray room that was voted on. And then I just wanted to keep in our back of our minds, emergency power needs coming up and roof repair needs coming up, not right away. Any questions about those words or tonight?
Questions? Carry on.
All right, on page 39, your key statistics, it's kind of the same story again this month. Outpatient surgeries, ER's a little bit flat. Rehab, observation days, I'm starting to feel like I'm a broken record a little bit on that. But it is what is happening there. Otherwise, that's kind of the story that's gonna show in a few minutes. So if there's no questions there, we'll just go on to the year over year. That year over year, it's just telling the same story in a different way. Projecting for the year end was to be at a 0.% margin, although we're really doing some work around seeing how we can get back to budget there. Let's see, anything else that you have questions on those? When you look at I was thinking about the FTEs earlier and the fact that sometimes we run close to budget. We know we're still hiring people. Really, a lot of that overtime feeds into those FTEs, so it's not really as clear a picture as one would hope. Then AR days, well, let's just go to the financial dashboard because the AR days graph is something hovering right around 55 days this month of 53. That's really my sweet spot, as I always tell you. A little bit anymore, be less days than that, and I start to worry you're just writing things in. But we are that the revenue team is killing it in size. So I'm just really proud of them and what they're doing. Our operating income
sneaked over the zero line. Cash and investments is up a little bit due to the timing. The last few months, we've had timing in bad timing days for our days cash. This month, we happen to have a good timing. See when I get to the balance sheet. Questions about that? On to the next page, our statement of revenue and expense. This again, same story we've been telling. Revenues under budget, over last year's actuals, but still under budget. The deductions from revenue, that's where I hope to pick up some dollars next month as we look at those cash collections and the denials going down. The results of the poppy work that the revenue cycle team has been doing. So I hope to see that a little better in line with budget. That will help our total operating revenue. And then you'll see salaries as we go down the line, salaries, temp labor, benefits, they're all the same story of having holes in our schedules and having to have agency staff. And it has hurt us a little less this last month than it has been. I know we have some work around recruiting that we're gonna see, and we're gonna see results of that. Our UKG system has really been giving us really great information. I think I talked about the missed meal and bus breaks last month, and this month we saw great improvement just by visibility of that, I think. So I was really happy to see that. And overall, our expenses were just over budget by $540,000, and our operating income was just eked over the zero at 115,000, like you saw on the graph. And our tax levy revenue ended up with just under 600,000, which feels a little better, but want to see that improved as we go over the months. So are there questions about that? Yep.
Purchase services, again, that's travelers and stuff, right? Travelers,
It's a purchase services is not temp labor. That's up above.
Oh, all right, sorry.
Those are like a lot of things that Trent spends money on. And contracts we've signed, certain things like that. I have already given Trent a heads up that we may be looking at that, because I think that's an opportunity for us to get back to budget a little bit better there.
But yeah, it seems like, I mean, if you look at the travelers, I mean, we're spending a lot more on that, but
Yeah.
just services, so. Yeah, all right. So, yeah, I mean, I guess, we're getting temps on the backs of, less purchase services. I mean, I don't know. I know it's not a one-to-one thing, but.
Well, it's different services too. The temporary labor and salaries would be more years. Partner that you're looking at. I would normally, I budget salaries at fully staffed, and I add a little bit in agency where they think they're gonna need some travelers. So if budget is right, that will always be a little bit over budget. But your salaries should see the other side, right? So we're
Yeah.
seeing on both sides.
Yeah, we're spending more on salaries
that's
and
why
temps.
A lot of overtime, a lot of agency, just because it's told in the schedule.
I mean, obviously, the goal at some point would be to not rely so much on them.
We're running about 10.3 FTE in agency staff. I only thought we were gonna have, I think, 5, so.
Thank you.
Any other questions on that?
Actually, what is check out the FTE?
Oh, sorry.
Staffing, but how about like, is that physician too, or? Sense of
That ends up in professional fees. So
Professional fees.
zero local.
Where you have agency.
Not for provider. When the first one will be trying to open, we don't have any guns currently for providers.
That's not gonna.
Yeah, a year, 2 years ago.
Yeah.
We've got, but yes, we will have the one more gun cardiology, so in July. So we'll see those. They take forever to go, so.
Any questions on any?
I just comment, we have a lot of staff on FMLA's extended leaves absences. Since the state changed their FMLA laws in 2021. Seeing that across the industry. I think we're about 10% of our staff are on FMLA, and also I know somebody at another hospital, they're up to 20% of their staff on FMLA.
We pay them and you pay staff to cover them.
And it's usually an agency over time. Where you're hiring and then you're just committing to hiring another full-time staff. You want to be hopefully 5%. I know the people they should. From your recent hospital or is that too?
It's increased everywhere I've been. So I think that part of what we're learning to do is look at how we're staffing schedules. And then what can we do to cross train and make people a little more agile thing around. So we spend a lot of time assessing that. And then one of the things I'm going to do with recruiting is really focus on doing some sourcing and how can we look for people that maybe have experience that can flex a little bit more.
Is the idea there that you would fill in the gap of those people to avoid, among other things, overtime?
Right.
On to the balance sheet. And really, like Daniel was saying, the balance sheet just is what it is. It sort of doesn't change a lot in our organization, but you can see that cash and cash equivalents is up. Last month is up quite a bit. Some of that is timing and some of that is active that release I can see collected. I think the most they've ever collected is over 13 million. So that will help us look in our allowance estimate and some judgments about that.
Yes, just to throw into perspective too, and just like we just approved a lot of capital. Spent a lot of money, 2.23 million, a lot of money.
Yeah.
And we collect $13 million of organization for growing organization. It's a lot of money.
So. Unless there's questions, the only other thing that changed a lot on your balance sheet, our balance sheet, is the out to you, the other receivables, and then there's the deferred tax collection. They sort of offset each other. We haven't had that big of a receivable and a liability. We book the same amount every month and it comes in waves like this. So that's why that looks like that. Otherwise, I think unless you have questions, there's just not a whole lot of interesting things on that.
So waiting now. The cost of pulling it.
We are, and that's not, oh, like he did get that book. So that 1.5 on the third party receivable. 1.2 of it is from our 2025 cost report that we will be getting. Other 550,000 is from our estimates on year to date now on that same cost report. So no, that was interesting. And then cash flow statement on the next page is just saying the same thing again, sort of telling you where the money went, coming from the income statement to the bank. Started out the year with $5.9 million, and now we're sitting at that 7.5, almost 6 billion. With a net book income of 3 million. The reason that it really changes is the appreciation gets to add back. We never spend that cash. Capital. But so we get to add that back. So we have added $7.7 million year to date. Then there's your AR days again on the next page. I'm just so proud of those guys and they're collecting and they're really working through the accounts. Right now they're, credit balances and getting self-pay onto payment plans or getting them through the system so we don't sit on the books for a long time. So this goes to them. Really proud of that. Questions on my accounts receivable? And then the investments, you'll see we have no more of those teeny tiny yields left. Last month, June. Last one came sure. That was under, I think it was under. Now we're up in the 3s, 4s. And all those investments to cover our debt service. We have that debt next year, but I think we'll that's my report, unless you have questions.
Anybody ever thank you and the members of your team for giving us helping us have a clean financial audit? I mean, that's it's I mean, there are a lot of complex
They do good.
yeah, so I mean, I know it takes a lot of work. It's not just the financial health, but it's the fact that, I mean, the audit is about whether we're properly monitoring and keeping track of everything. That's
And you're making your decisions based on good information.
anyway, thank you for that.
I will thank them because I don't do it.
Thanks to them too.
Any questions or compliment to Jennifer? They work very hard. It's always fun to be a part of it, see it behind the scenes, all the work they're doing. So thank you, Jennifer. That brings us to the Chief Executive Officer report. Jason, what do you got?
Thank you. I'll just comment on a few things in your report. First one, just want to give kudos to our provider recruitment. We do have Dr. Sarita, who is an internist that we look forward to starting in the fall. We're hoping for. So he's one that we're sponsoring through the H1 the reset program. So really excited that that is starting with us soon, hopefully. Yeah, this is the first one that we've looked through in this. Dr. Fang was a slightly different program. Couple other comments, the RHC expansion, we are looking at kind of the same style with emergency room, so it's been out with staff looking at, we've got a lot of different versions coming. I look forward to getting that in front of the board in the next few months, hopefully, to get some projects going in that clinic as well and expand ability to serve more patients out there. A lot of demand up there for primary care, and that'll give us more room to recruit a couple more providers up there. That one also, like the ER, we'll be looking at phased improvements on this internal work, and I think it's phase 3 or 4 that it goes to building outside. So we took each one out of phase. Each one we can do one is phase. So I keep moving forward. And each one builds on each other, so not wasting from the first. And not having any disruption. UKG system, what did I say? Thank you, Jeff's team, for picking up and trying to learn everything that's going on with the UKG system. Ginger and Ally, and Bill meetings, I've been meeting with all the managers to learn about their pinch points and trying to make some adjustments to that system to help serve our customers better. It's a lot of work still to go on that system, so it's pretty big team work. Mission, vision, and values. So I wanted to ask for a board motion or authority here. It's been, I believe it's 2016 when we revisited our mission, vision, values statements. Kind of randomly been touring around through the hospital asking employees what their mission and vision statements are. And I yet to have anybody get it even semi-right and still have some words in there. So it hasn't been revisited in a long time. I think it's a good opportunity for the executive team to work with leaders, to work with all their staff, to really have a grassroots or those ground available statements and what they mean to everybody within the organization. So I'm gonna ask the board to consider that, and this would be a good time for us to tee off some of that work. I'll be looking at, Jennifer mentioned that AWPHD often offers grant money to support facilitators to help guide those process, link them into that. So I'll be looking to see if we can get a grant to get facilitated for that. They said, yeah. Thanks.
All right, so you're looking for a motion?
I would love a motion.
Questions, you can ask them, otherwise I would entertain a motion for the mission, vision, values refresh. To get the team started on into that.
Still thought that we would aggregate that information within the organization.
Yeah, together with staff, and then it'll just get tighter and tighter until it comes to the board for adopting. So I would envision like sticker charts and stuff on the walls in the mezzanine or somewhere, people to come in and kind of vote, rank things as we start doing it.
By Bob,
I'll say yes.
second by Erica. Any further discussion? All in favor of moving forward the mission, vision, values refresh, say aye.
Aye.
The two vote aye. Anyone opposed? That motion passes.
A couple of other just comments. We do have a new fire. The fire department board of commissioners did have representation from the hospital. We had not listed on that committee for reviewing candidates, and they did appoint Greg Reitner as the new fire chief. So it's exciting to see them get that position filled and to have that partnership. It's stronger and stronger.
If he was local or came from?
Came from Rose. Right, and I know him.
Continuing the work with our coffee to improve our interfacility transport situation. We are looking at talking with outside agencies, talking with our local partners, and trying to work towards a solution to help us streamline our facility transports for all patients. Regardless of age, patient type, behavioral health, really trying to look at what was the best most route. So looking forward to seeing what we have in the coming months. I think we're getting closer and closer to that. Is all that I had to comment on the CEO report. Any questions?
Any questions for Jason? Right, so we're gonna move on to education and board reports, but at this point, usually take a couple minutes to just stretch for a second. And then anyone who's given their reports and is done for the day, I welcome you to head on and enjoy your evening. We're just gonna have a lot of board discussion. Completely welcome to stay also, but just know that next minutes are due. If you're done, I just need Janelle to stay. And I don't know if you need anyone else.
Just Holly and Janelle is
Okay.
all I request. Executive.
Yeah, so anyone else who wants to go about their evening, feel free. On in a few moments with more discussions on different things. Thank you everyone for your efforts tonight.
But it's what I sent you.
On the screen there? No, you can print out. We want to see if we can one of it. No, later. Once you get a copy, feel free to send it to us.
Yeah, so I tried to play that up and it is inside. Or it was made. Yeah. Try to put it so-
Yeah, I'd like to do this.
Well, this, yeah. Yeah, education board reports of old business. Business then, and so yeah, it's just in like.
First.
I went to pee. It's like, was that some old ladies?
I know, but I was.
Yeah. Yeah, they go off to dermatology or something.
Great aspirations.
Right, tell somebody about things.
All right, so let's go ahead and carry on with our business here. We're on to section 8, old business, KVH policies.
Before that,
Oh, sorry, go ahead.
education, board education.
It's been sequential. Correction, we're going to start with section 7, education and board reports. So we had the Rural Hospital Leadership Conference at Chelan. And so do we have any board reports for this conference?
Yeah, I'll start. So I took a lot of notes, which I sent out to everybody. Feel free to look at them if you want. A few takeaways from that meeting. I thought it was a really good meeting. It got a lot of nuts and bolts issues that commissioners have to deal with. So, for example, I really welcomed sessions on public records and public meetings, what counts as a public record or a public meeting. I learned that one of the things we're concerned about is having stuff on our personal devices, texts and things like that. We've been very good, I think, board about not having that stuff on our personal devices. But the state law is that if there is some thought that some of that is on a personal device or personal email, you don't have to turn over the whole thing to the authorities. What you have to do is just turn over what you find on there and then sign an affidavit that that's all that's on it. They also talked a little more about when an individual board member can take a position and how and what circumstance and things like that, which I thought was really formative.
When you say a position, are you speaking of an appointment?
No, I'm talking about
Oh, a stance.
political
Got it,
stances
okay.
or supporting candidates for office,
I
and
see what
things
you're
like
saying.
that.
Okay.
But it's good. Yeah, it's a good clarification. One of the things they talked about in the session on political changes is that we need to be proactive, and I'm sure people in the organization are aware of this. This has shown up in a couple of reports, but be proactive on these Medicaid requirement changes under HR 1. Work requirements, the re-enrollment stuff, the frailty requirements, which I guess is still being hammered down. So we have to really, again, I think you're all aware of this, but we really have to, as an organization, assist people in re-enrolling and fulfilling these sort of work requirements so that we can keep them, on Medicaid, and so it doesn't turn into, charity care or something like that. Another thing that I thought was really interesting was, and this came up both at the WISHA meeting and the AG meeting, is this issue of patient transportation. Like how many appointments are being missed or follow-up appointments are being missed because people do not have transportation, someone to take them to the MAC or things like that. So this seems to be a challenge for a lot of people, and different organizations have responded in different ways. I forget which organization it is in Washington State, but they sort of have their own driver, van and thing, and they just bring people to appointments. I talked to a guy who had a poster at the AHA meeting. Lyft apparently has grants money that you can apply for so that you can get medical transportation. So, and some people have addressed this by having a lot more telehealth options, even for providers who are in the organization and on the campus. They might have a telehealth appointment with someone who has transportation issues. So someone in their, would stay in their house and have a telehealth appointment. No one needs to answer this. I'll just ask it as a rhetorical question, but I wonder if we have any data on how much of a problem this is for people in our sort of service area. If this, I mean, I know that Ellensburg is fairly small, but Kittitas County bigger, and there are a lot of people maybe out in rural areas who may have a problem with it. So again, I'm not asking for an answer, but I'm just curious if as an organization, we know how much of a problem this is for our sort of patient population. Anyway, those are my kind of three big points or takeaways from that meeting.
Thank you. Terry, you were at Lake Chelan for the conference. Do you have any thoughts or comments from the conference you attended?
I wasn't gonna add any more than he did, because those are the ones that I thought we could really talk about. And thank you, Leo. I don't have anything else to say. You were there. Do you have anything you want to say?
Yes, I was going to get to that. So first of all, I really appreciate Matt is so thorough with his notes, and I do read them when you send them. So I appreciate the effort you put into collecting all the information from every segment there. Yeah, the broad stroke takeaways for me, again, on the board side, they really suggest that we try to spend a noticeable portion of our time discussing things as a board, because this is the one time we can get together during the month, all five of us are here, and to make sure we're pushing ourselves on the topics that, again, look more into the future than in the immediate problem. Like a lot of the rest of the media stuff that's happening right now. This is what's happened last month. And again, they just encourage the board to find ways to bring topics in, especially during this segment, old business or new business of the board, educate ourselves, have conversations about it, so that we're staying ahead of things. We're leading us to the things we want to think about, suggest the vision, so to speak, and whatnot. So again, I appreciate hearing from other. I attended the board chair lunch, and it's always good to hear what their other organizations are doing and so forth, and know that the challenges it could be on an elected board. I feel pretty good. We have a very solid board. We have people that care, people that put in time, and talking to some of the other chairs. Not every board is as efficient as ours, so I'm proud to be part of the.
About addressing upcoming issues. Did other organizations, commissioners from other organizations, and indicate that they were doing that actively, or that they kind of.
They struggle also. It's because something has to instigate it.
Right.
And again, that's why the immediate stuff is so much easier. It's right there. This is the problem. Let's talk about it. Versus that vision. What's the problem? And I think the big one, Matt already touched on it, is these changes at the federal starting in January with the new Medicaid rules. In a rural hospital, that could have a huge financial impact a year from now, 2 years from now. Begin that discussion. What, if anything, can we do to prepare for it? And again, some of it's already in place. Admin already is in there. I know they're doing things, but the big one again is these new rules with Medicaid. It used to be the 90-day look back, so you could really help somebody get coverage even after something bad has happened. And they've shrunk it to such a small number in the near future that it makes it really challenging to follow the rules and get them coverage so that they can get the care they deserve. So again, just suggesting that we pick these topics and find time to talk about it.
It's the best way. Say I'm encouraged to talk about something. I think of an issue that I'd like to discuss. What is the best way for us to agree that that's how we would get it on the. We just need to email you. Someone would like to discuss this. Please arrange that. I'm of
the feeling though, even though I'm in the role of chair right now, we're all completely equal. So I don't think you would need my permission to put it on. I would think like in this new business discussion, you could bring it up immediately, or you could say, next month, I'd really like to have a thorough discussion about this. It'd be helpful if you guys read about it before that, or whatever
I like
is
that.
your request.
So I don't want to, drop a bomb on it.
Yeah.
Hey, we're gonna talk about this right now, and I want to hear from all of you because, on
Yeah,
the
but to
spot.
plant that seed that
Okay.
in a month or two, I'd really like to discuss this. And
Sure.
here's maybe some
I like that.
starting material I came across. If you can read through it or research it yourself, let's have a 15 or 20-minute discussion that merits that. So,
I like that.
yeah, again, I would encourage anyone to say, this is something I think our hospital system should be thinking about, and we as a board should be thinking about. So again, one way of saying several of my sections kind of circle back to that same thing, that we need to be a little bit more proactive of the vision, not just the immediate problem solving and so forth. So I did appreciate that. Yeah, so I think that's for the Wisher conference. I think that's enough comments for there. So then two of us went to the leadership conference also, which coincidentally was much too close to the Wisher conference, but they put them when they put them. Matt, do you have any thoughts about the leadership conference?
Yeah, so again, with that one as well, I sent out my my notes to everybody. So if you're interested in more specifics about what was talked about there, feel free to look at those. Few takeaways I had from there. There was a real focus on job pipelines, which I mentioned earlier. There are a lot of people doing innovative things with local high schools. Heck, there's this one place that has like a health professionals high school, which was, I mean, it was really an interesting approach. But they're, so they have a lot of relationship with high schools and even elementary schools to try to get people thinking about working locally. And then they also have ways of developing talent internally. So this notion of upskilling, which I'm sure you're really familiar with that. But this idea that that you would always be sort of getting people into more challenging positions and helping them get educated. So at this one place, for example, they help, the organization helps pay for continuing education, but how am I supposed to find the time to do that? Well, what if we let you do that for the first part of your show? Whatever, go to class. Anyway, so there are a lot of kind of innovative ways that people are trying to develop talent locally and internally. So if you're interested in that, I'd suggest you sort of take a look at some of my. There's a lot of stuff on AI use, and I know that John will probably say more about this, but it's in all different aspects of the organization. So we have some in EHR documentation. AI drafts the clinical notes, and then the clinician sort of signs off on it. But some people are using AI for automatic appeal of denials for payment from. So insurance companies, at least in California, I don't know what the rule is here, but can't do a denial based purely on AI. But we can use AI to automatically appeal denials of payment. So that's an interesting idea. And then there's some people who use it so that people patients can talk about billing issues, call in and talk with an AI, system about billing issues, even after sort of the regular workday or even on weekends, things like that. It really helps to facilitate a lot of those things. And there's an AI sepsis early warning alerts and things. So even in the clinical space, the financial space, in the sort of, revenue space, AI is being used in a lot of those places. And then the last thing is just a very brief thing. One of the poster sessions, they talked about having age-friendly patient advocates in the ER. So you might have high school students who are trained to do that, or other sort of volunteers in the community, but you would also train maybe some of the clinicians who work there, with the idea that older people sometimes need someone to advocate for them. Not everyone has a son or a daughter or a sister or brother who can sort of come in and advocate for them. So you would train people in the ER who would be tasked with doing that for them. I thought that was a really interesting idea, and Mandy may be interested in that, and Holly. Anyway, those are three things that really stuck with me. John,
Yeah, so it was a good conference. I decided on this one to focus almost exclusively on AI. So I think I attended every AI session that they had, and it was interesting to hear from the large companies to literally the startups. Just they spent some time with one, two-person startup, cliched graduate students who dropped out of college to fund this company by getting financing from some of the people that funded DoorDash and, other companies like that. So they have some startup on it. Jason and I actually had an opportunity to do a Zoom call with them, just to kind of pick their brains about what they're doing. And ties into what Matt just said. They're focusing exclusively on denials, using AI agents to do all the prep work and present it to the provider for a signature if he or she approves with what it came up with in the denial appeal and so forth. And got Jeff on some of these calls. And so for me, it was educating myself what's out there, and it is changing so quickly. A year ago, I harped on AI a little bit when I got back from some conference or something. And like one organization now that I saw, one of the larger ones, they said they're deploying over 260 AI agents within parts of their hospital system. They deploy about 10 new ones a week. They have about a 70% success ratio, meaning about 70% of the time the AI agent proves to be worthwhile. It's doing something that has a return on investment, productivity, efficiency, and so forth. And they just keep churning through them as they figure out areas they can target. And then again, very small implementations where somebody's just touching their toe in the water to try something and see if they can make it more efficient. So coming back with that, I spent some time with Jason, spent time with Jeff and Jennifer also to share what I learned. And then Jeff's able to share what we're on Oracle/Cerner. And so we have, a very high level organization that runs our electronic medical records, highly secure. And that also plays into who can just play in your pond if you want to try to add AI agents and so forth. So it's going to be a long process, but it's kind of thing that starts by asking the questions and just saying, are there things out there that I'd rather be proactive than reactive? I don't want to wait for it to pass us by and say, what, that exists? I'd rather know it exists. We'll be having to talk about it as a board, talk about it as a senior leadership team. Are there tools out there that are evolving quickly that would help an organization of our size be more efficient, help our patients have a more successful, movement through the process that they go through? So
just to emphasize what John said at the end there, the notion of improving patient experience, improving efficiency. One of the messages through this whole thing was, don't just find a fancy new shiny toy and try to find a place for it. You want to think about operations that can be improved and then go look for the tool that can help. So you don't want to put the cart before the horse. It's not just
so
about
Matt's stealing my punchline, which I like. It's they made it clear. Make sure you're starting with a problem. Don't find a solution, then go looking for a problem. So start with the end user. What is it you're trying to solve? Now let's see what's out there that, could be better than what we currently have at a price and value we can afford. So again, it's mostly just gets the mind thinking and just realize what other people are trying. And again, some institutions are all in. They have whole teams now on site that are helping them implement this. Now, these are much, much larger organizations than us. And one of these facilities had 10,000 nurses on staff. So this is a large organization. But again, it's scalable in different directions, both up and down. So I've enjoyed conversations with Jason and Jeff and Jennifer since I got back, just to see what they're thinking about it. And again, at the end of the day, we're here to just support whatever's best for the institution. But it's fun to be a part of, again, that brainstorming and whatnot. So
the only thing I'll add is just that I want to thank the board for approving our being able to attend these meetings, and thank Jason for supporting our attendance at these. We do really try to get value out of these educational opportunities and to improve as board members and also to improve the organization from what we learned. So thank you.
Again, Matt has a skill that I don't. I cannot type and listen at the same time. So if I start typing, I stop hearing what they're saying. So I just listen and I rely on Matt's notes when he sends them to see what I missed. But yeah, so again, very educational, very hot in Denver. So
Thank you both.
Yeah, I appreciate you all doing it. Obviously wasn't able to go to July. So I appreciate you guys bringing that back and the enthusiasm and excitement, and just it helps the momentum to bring those things forward as well. It's all touchy areas. It's sensitive on so many levels that I can't do that. Reluctance to even think about AI, to people taking my job, to I'm just too busy to do one more thing type of thing. So it really helps to have these discussions and have that real support and enthusiasm from the board.
One cautionary tale, sorry,
Go, no, go.
one cautionary tale I heard was if you sort of got AI to start kind of doing these appeals, and then you got rid of everyone who, you know, all the people who did that sort of thing here, then what happens when you have to re-up the contract? They've got you over a barrel because no one in the organization can do it anymore.
Keep the institutional knowledge.
Yeah, like United Healthcare getting their cyber attack, and they were trying to bills out via the mail. Not many people have ever done a paper claim. So yeah, you don't want to.
And I never really think of these agents as replacing people. It's taking the stuff that is not
to make it scale.
stimulating for a person, that's a computer can do really quick, and get them onto something more interesting. Human needs to be stimulated a little bit, so.
Yeah, help people to do their job better.
Yeah,
Appeals or prior authorizations for medication. It's just a long, boring form. You gotta go and scour the EMR, plug and play, fill out these, and then service to really automate that.
Anyway, thank you to the board, and
Yeah.
thank you, Jason, for
and do not ask me about a 6-hour trip home took 18 hours. Just don't bring it up.
Oh,
Yeah.
gravy.
How many times we went out to the runway and they brought the plane back to the gate? We're not gonna talk about
I was
I know one of them.
it. You're simple.
I loved it.
Oh, that's great. Good.
On prior authorization and appeals, and then we did go and poke Cerner as well to see where they're at in their development of that. So I look forward to learning a little bit more where they're at. It's usually a little bit better to use like what's already integrated and built into our Cerner system, but they're oftentimes behind. So a good example is
Go ahead, I cut you off.
just like scribe services. We started 2017 with in-person scribes. Then we went to phone-based scribes. Then we went to separate vendors, AI-based scribes. And then after that, Cerner's finally have their integrated scribe system. So now we're on Cerner systems. So some of these will be an evolution where we have to get comfortable plugging into our EMR. Every time we do that, it does come with a little bit of risk.
But it's frustrating. A company decides that, you know, they just put out there, this is what we're gonna do next, try and scare people away.
Yeah.
And it reminded me that Elon Musk does this all the time, you know, he tries to clear the space by saying, we're working on it, and it's frustrating. I really, because I enjoyed meeting some of those smaller companies. If you, they would hustle, they will pick up the phone at 9:00 AM on a Monday and have you an answer by 10 AM. And Cerner's not gonna do that, so it's a catch-22. I wish you well sorting it all out. So, all right, anything else on these conferences? I think that one pretty good. All right. Now we're on to old business. We're going to discuss KVH policy discussion. So we're heading off to you.
If needs be.
So within the packet is the policy, and I know that Crystal had the opportunity to meet with Matt and Erica and review the policy to now have a policy on facility appearance policy. So welcome. But
Yeah, I just want to ask one question. So in the packet that I got, I have a hard copy, but I believe earlier today you emailed copy. Is that accurate?
Yes, it's,
Do you know it's identical? Okay, because I was trying to do it on my cell phone, compare the text and see if
it
it's
came straight from the stock.
okay. Because I couldn't find a date. I found a date.
There
The
would,
guy was 7/16 revision date on this paper one. I couldn't find one on the one you sent.
Because the one that I sent is the actual written policy.
Okay.
It's rather than the one that Mandy put in here is the one that came straight from our online platform. So it has the
As
date.
long as it's the same, that's all I need to know.
It's
So
the very last page. It has the effective date, like kind of.
Right. He's talking about.
I thought she sent me one. I was trying to confirm it was the exact same. I couldn't find that date on the one she sent, so I had to go through it word by word. Worked it out.
so last board meeting, just a reminder, we did adopt our first draft of that policy. And then so we could make that effective that day, and then for Crystal that weekend and that next Monday to make that effective and do some awesome things with it. This is the time to just then, we've had a little time, Matt and Erica, to play with it a little bit and then finalize it. So we just be looking to amend the policy on motion of the board since there's a motion last time.
Matt or Eric, was there, you want to speak to the, where, how we got to this people here?
So we met with Crystal. I thought we had a really great conversation. It was a little funny that we both said, well, neither of us really wanted to drive it because governance, but we both had a lot to say. So,
Is the we, you and Matt? Or you
yes,
and Chris?
sorry, Matt and I had
Okay.
a lot to say, and Crystal, thank you for helping facilitate that. And I really appreciate your thoughts and ideas that went into this. And when I had questions about a certain passage or why something was written the way it was, Crystal was able to give some context for that, which was helpful. I think that what we landed on is good. So I'm pleased that we now have see the income has the concerns that to us that gives us some direction and answers questions for people, and also gives us a way to recognize some things that we're just not policy.
Yeah, I mean, what Erica said is right. It was a very productive conversation. Thank you for sitting down with us. And yeah, we were trying to the other sets of eyes on the policy and give you some sort of suggestions, but in the end, we tried to make it clear that now it's sort of your it's up to you to go and kind of leave the stuff we said and sort of write the policy, because this isn't a board level thing that you need to approve. It's we don't want to get into operations. So I think after we gave our feedback, we sort of said, all right, we trust you, you do whatever you think is best. And I know that's kind of hard, and being in a board position, it's sort of hard maybe to just kind of say, well, just disregard some of it or something like that. Hopefully you didn't feel too much pressure from us, and you heard from us that we realize this is operations, and I trust you to. I'm happy with whatever you did. I certainly am not going to ask for any sort of revisions. I think what you did is fine, and not that my opinion necessarily matters at this point, because I know it's in place. It's a policy already. I guess I'll just say I appreciate you listening to us, and I think good job. But I don't think the board has to actually approve or anything like that. It's in place. So.
Can I just ask, were you able to reach out to the various stakeholders and get input?
I did talk to them, but the truth is that this policy really didn't address some of the concerns that were at the board meeting. This was strictly about what goes up in our facilities. This wasn't about the incident in question, really. But this was something that we needed to have in place so it could facilitate these conversations moving forward. And just so that everyone is aware, if you weren't already, Lucidoc, where we all of our policies and procedures are maintained. Every year, annually, we get a notification. Hey, you need to review this. Take a look at it. See if there's anything you want to adjust. So I think this is a great foundational document, and we can be looking at it as a living document. And in a year, we'll make any adjustments that maybe come up throughout the year, which is helpful.
Some things may not be apparent. Right. They might make themselves apparent. That revisit.
And we started with a rather strict framework, if you remember the last version. And part of what we did in our meeting was, can we simplify anything? Can we eliminate some things that are wordier and they don't actually get to the root of what this policy should be in place for? And we did I think a very good job at that and sort of condensing it down to this. I think my favorite professor in grad school, I remember writing this incredible paper. It was incredible to me. And she goes, simplify, clarify, focus, simplify it. And I think that was some of the mentality when we went into this is what can we simplify?
So this policy as presented here is the active policy. Right. Is that accurate? Anything else you want from us regarding the policy?
Oh, so I don't need a motion. I think
All right, anything else you want to say about it? Thank you for your efforts on this. Appreciate it. All right, so that is, taking us to new business. So for new business, we have, board meeting packets and reporting. So this is one of those areas where the board takes this opportunity.
What's the strange hissing sound that happens? Okay.
Identify or.
Oh, this.
The record.
Oh, it's like the best now, so off on the something back here. Okay.
Should I duck and cover? What should I do?
Good, it's gonna be cleaner, that's all.
Good. All right, so under new business, we have board meeting packets and recordings. Again, this is an opportunity for the board to discuss if they have any thoughts or recommend any changes. And I think that the gist of it we're looking at is, in today's world, you got to be as transparent as possible, how to minimize anything we're doing publicly to be used against the hospital. Because there's a few nefarious actors out there who will learn through public records requests. They can try to get to the point where they can sue an institution. They, again, we want to put it out there so the public knows what we're doing and just, they can contribute, they can be aware of it. But we're finding a lot of what's coming from our stuff we put above and beyond the legal requirement is coming back in a negative way against the hospital. So we just thought it'd be good to have a discussion, see what people are thinking. Is there any changes we want to make? Materials or anything related to these meetings that we do as a board? Obviously, we have to follow the law, but beyond that, it's discretionary what we want to do. So I put it out there for anyone who wants to share a thought.
In addition to individual sort of nefarious actors, Jason was talking about how some competing organizations might use AI. I mean, Jason, talk about how if too much information is put out, how it's being used by.
Yeah, like business advantages is knowing information, right? So it's so much easier now for people to train bots. Like Jennifer has created a bot through Claude that will go out and look at all the insurance payers once a week and look for any changes in their payment policies. And then it just comes back and says a little summary of policy changes at these 3 payers and like policy changes, which it's coming through in minutes or maybe hours because this is so large. Hundreds of thousands of pages of policy documents. Like there's so many policies of insurers. So it's that same logic that organizations can use. Private equity uses it. Bob's spoken to that before, where they just go and scour everything they can about these organizations to learn where their next targets are, or where the next opportunities are to maybe catch an area of opportunity and disrupt the market, whether that's good or bad. For us to work through and know it's out there. The Bob was talking a month or something about somewhere you can really kind of drill in on that. So that's something that's out there within. We did go and look at a lot of the other public hospital districts in the state and couldn't find nearly as much information on the websites as ours as far as financial. Especially. Then the other vulnerabilities it opens up is just fraud. The more people know about an organization or an individual, here it is with fraud. Jennifer forgot to mention we do have a bank account fraud going on right now. So somebody has created our checks and they're signing my name on them, which feels very violating. But I'm getting about 3 checks a week with my name on them today. So those kind of things where they know a little bit about the organization. Give a little bit of it. Have on the bank account when they can. So they aren't getting cash, but they are still being presented. And they're also on those, again, technical abilities. They go to these banks that are notoriously known for not being friendly to helping those people. So these individuals know even where to go and try to cash these checks. So
I think in the last couple of years, effort it takes to cause problems has been so greatly diminished that we just have to acknowledge that. Again, besides the changes we want to make to push back, to make it harder. And, you know, even the videotaping we put on YouTube, the computers now can scan through that in a few minutes and pick out all the important details. And it's just, again, it's challenging. You know, I've been sued for something I have said in this meeting that they felt didn't match something they, you know, so the only reason they did that is because it's so easy. If they had to sit here and watch the meeting and take notes, they would not go through that process. But there's no, doesn't cost anything in today's world to attack a public hospital district like this, who they know has to make everything so public and do everything so public. Even this discussion, it's absurd that we have to have this in public because we're acknowledging a weakness, a vulnerability. That's not the smart way to conduct business, but that's the law. So here we are.
Yeah, 2 years ago, we had an individual target us and we ended up settling, I think it was about $80,000 rather than going through just the efforts of harassment that not from those. But that individual, this is their full-time job. They have targeted another local public entity in Kittitas County. Currently, what's going to do that with this same individual? They have, it's kind of like a fishing, but a very trained fishing, and they're very successful. Ways as well. I would invite Rick Thomas, probably the most fluent in AI, probably based in the room, but I don't know your guys' skill sets, but I would invite any questions as well if you have any comments.
The other thing I would add is that there are other dimensions of vulnerability that exist. So in all of our board reports, we report out on the individuals who are right here in the room with you, and other members being great talent to our organization. That is a data set that's right for coaching for competitors who would want to coach away that talent. So if somebody were looking for a talented CIO, could easily identify all the work that Jeff and his team have put into defending our organization as an opportunity to coach away from us, putting us in a situation with disadvantage, trying to replace that talent. I think that our clinician talent and leading to the conversation about trying to avoid turnover amongst our clinicians for our community is an area where we should pay special attention, recognizing that they are highly valued commodities, which aren't easily poached away for very small sums of money differential of salaries. So I think there are a lot of pieces of information that are disseminated through this communication meeting. It could have a detrimental impact on the organization if they were by unfriendly actor, necessarily fraudulent.
You see, even voice is now data. We were going through one of those demos was a call center, and you can choose from these 30 voices in 18 different languages. Or if you don't like that and you want your own voice, you just say these 9 words, and then you are now the voice for that call center. So it's pretty amazing and scary.
We've heard a lot about that side of the equation. I mean, on the other side is the idea that we're a public hospital district, we're elected officials, we want to be as transparent as possible. Well, maybe not as possible, but we want to be transparent. We don't necessarily just want to do the bare minimum. I mean, I'll stay out of this because I'm sort of I can't figure it out. I mean, I'm of two minds on it, and I'm not sure I have a solid sort of really on position on it. I see reasons on both sides, so I think I'll just defer to the majority of the board. I would be interested in hearing a member of the public who's been very interested in what's happening at the hospital and monitoring, attending our meetings on behalf of League of Women Voters. How do you hear this? Does this sound like, yeah, that makes sense? Maybe you would want to restrict the information going out. Or as someone who's attended these meetings, do you think, no, do you understand the concerns, and does this sound reasonable that we would sort of trim it back a little bit? There still would be a lot, the agendas would be made available. People could still attend the meetings. It just wouldn't necessarily be recorded. We wouldn't disseminate the packet electronically. Is this what I'm hearing? So but you would still be able to get a hard copy if you attended, right? I mean, this is what we're talking about. Do you have any thoughts So I don't know if this is against protocol, but I'm curious if you have any thoughts on this as someone who is taking advantage of the fact that this is a public hearing.
Always impressed by these reports. And then person who wrote the report or that department highlights the important stuff. And that's what I go back and report on. Highlights.
Do you think it would be sufficient to just have the hard copy?
Just have the hard copy, yeah. AI scares me just as it is, so I just.
Clarify when you say it scares me. What scares you? Us changing what we're doing or what people can do to us because of what we're doing?
Exactly that.
Okay.
And the fact that he got sued and it's like,
We're just trying to help our community
yeah,
and you become vulnerable.
terrible. But it is the bad actors out there from various levels. I like coming to the meetings and hearing in person. I can't stand Zoom, so anyways, I think, yeah, people should try and get more people to come in person. But if you have to report it, you have to put it out there, so.
That's not a legal requirement.
Problems, and I think this is always been handled very cleanly.
Firmly, thank you, first of all, for being willing to share your thoughts. I was firmly in the, we need to keep doing this as we've been doing it, because that was so crucial. I came on the board, at least that was my conviction, and I've now entered the realm of ambivalence. I feel like I have a foot in both camps after the reports that are coming out of organizations that are struggled with people just. Maybe I'm a bit of a Pollyanna. Who would do that? Why would somebody do that? But regardless of my own thoughts on what I think is reasonable for people to do, there are people doing things that are nefarious with it. And it hurts me that happens, because it does push me into this ambivalence direction. I don't want to turn these things back. I want people to have the information. People that have the information. And it's just, as you see, it's so easy to get, and just sidestep here with an above ground pool at home. And it started making weird sounds today. And so I recorded the sound and I fed it to AI. I'm like, what is going on with my pump? And it said, this is brand pump. And it said, this is a non-recoverable. This is, your pump is toast, essentially. So, I mean, it saved me time. I've had a suspicion. It sounds pretty horrible. But, I mean, it was just so easy to do that. I didn't have to do anything else. I just recorded it, 15 seconds, boom, okay. And now I'm gonna get a pump. And it just made it not making money on that, but somebody who stands to have a financial gain, you know, that just really ups the motivation to do negative things with AI, or even without AI, and film it themselves if they want to be old school about it. So I'm in camp ambivalence about it, just pretty tremendous shift from where I was previously.
Terry, your thoughts?
No, I think we're definitely moving in the right direction.
Is it in that sense?
Full policy.
I don't know. AI, or not AI, but board meetings and board meeting practice and recordings, and I mean, really, this boils down to
So,
AI.
in passive,
I don't think that was a freaking.
yeah. Like the transparency that, by all of the. We don't get a lot of viewers. In the world we live in, that's a little bit different now. Unknown entity to get to is, or the board anyone. I remember several years ago, my clinic got swatted. So someone said, called and said, hey, I'm in a white van, I'm gonna come in and shoot people. And so you got anxious. Find out the guy was from Mexico, in Mexico, like he was threat. Had all the police healing. That kind of stuff. We're gonna see more and more creativity in what they're doing, so. I would be okay with.
So if we were to not publish on YouTube, we would still have it where people could attend live virtually, remotely. Is that true? Or Zoom, or was that organization Zooming?
It's up to the floor.
Why do we have it now? It's anybody can Zoom.
Yeah, anybody can.
Put a Zoom link on the front page of the.
We also recorded. Again, post on YouTube.
Wouldn't necessarily post it. but
We
would
have
still
to
do-
post the agenda and the minutes.
But not the recorded.
That's one of the issues. If you record it, it becomes a public record and you have to keep it and give it to people that request it. If you don't record it, you've not created a public record. That's one of the big things. Again, that's which to me, it's really changed in the last 3 years.
You can also record it if you want it for a record, and then somebody need to request it.
Yeah, but you've created a public record. You must now, because the other thing we talked about is video's huge files. And if you have to keep a certain number of years, you have to have a safe way to store it.
Could we? Is one of the options that we could do the Zoom, but be great.
Yes, that's the preferred.
And then another option is that we don't Zoom at all, but then that would really limit.
Well, at least if you Zoom, we have some idea of who's on them. And they, in theory, could report it themselves. But it's not our public record. But I again, from an accessibility standpoint, it's if we want providers, staff, people who it's not convenient to be here to be able to log in, and then we include the public aspect.
Right.
Zoom also.
Mandy, how much do you depend on the recording? Is that all
I go back to it here and there.
that you could do without it? If
Yeah, because once there's no proof, she can't be wrong.
Yeah. Yeah, the recordings are useful from time to time. I do like the recordings in with that from time to time. But not saying that I.
But you were
like
allowed to
them.
bring your own camera and document your own records. You don't have to keep track of.
Yep, so I'll just put my phone at the front. No, I probably won't,
Yeah,
but,
these 27 phones up.
Personal memory.
Yeah, yeah. Terry, do you have thoughts?
No, I don't have any more thoughts. I like what Bob says, and Eric, but I'm not gonna have any more to do. You were saying about it, I think it's really the best thing that we should be doing.
Because, again, I feel like anybody in our community are still accessible. They can come here in person, they can get a packet, they can log into the Zoom call and they can see it. So again, what I'm support is that we stop doing the YouTube recordings. Again, it's making it too easy for anyone in the world to know a lot about our hospital. And I don't know why halfway around the world have to know about our hospital. What good would come of it? I'm here to support local community, knowing anything they want about us. I mean, they can email me, I'll meet with people, they come here. We are accessible. I just don't want to be easily accessible to people who have no real reason to know about it. I'm not finding it to be helpful to my life at all. And it makes you not really want to serve as we get further into this changing world. And I also think that the documents, when we publish the whole thing online, again, that can be scanned in a few seconds with AI. I can just say, hey, pull out the highlights. What's interesting? And a few seconds later, it'll give me a report, everything that stands out in this sort of document. And like Dr. Thomas is saying, in today's world, it can be used for poaching. It can be used for lawsuits. Not many people that are worried about getting good care here, I think, go through the process. So the people we're trying to be open to are not the ones utilizing this for the most part. And, so again, I would like to see us stop doing the YouTube recordings for legal reasons and for safety reasons. I would like to see us stop publishing the packet, just make it here at the door for everybody who shows up. And if the Zoom calls not be recorded, they just be live and done. So we don't have that public records thing with really.
Is that a motion, or how would we phrase that motion?
Well, I'm trying to see if a majority of us feel that way before people slam down my motion and make me feel bad when I go home. So, that's what I'm trying to get to, is how people feel about, and I get it. The three of you in particular came in at a big change. And your transparency was like one of your number one things, because we had the hospital, I got to live through that 2015 year that you guys came to fix, and I did it. It was a changing time, but in charge, and he was very secretive. He didn't want anybody to know anything. So I understand it. It's just what we're fighting now didn't exist back then. It's just a different world. And we have to do what's good for the hospital and then the community, because the community won't benefit from the hospital if the hospital is severely damaged. If we're losing providers, or people are coming in because they know how to compete to us, because they can look at what's working, what's not working for us. Here's a weakness KVH has. Let's put a footprint there. And these billion-dollar places could spend a lot of money to take away things that currently we own. Make it real easy to know where are our weaknesses.
One of the things this is gonna do, if we do make this change, is Mandy, you're gonna have to sort through all the sort of legal stuff. So like if someone emails you and says, I can't make it to the meeting, could I have the packet? They have to come in and get it. Can you email it to, you know? So, I mean, we can make change, but then Mandy's gonna have to sort through all the sort of ins and outs of it.
But she would just send them a digital packet.
Well,
Yeah, but again, they at least have to go through that effort. Because right now, the bots can just scour the website, grab it. We have no IP tracing of.
yeah, but could someone from across, you know, from around the other side of the world, email her and say, send me the packets from last year?
I actually am working on a request for the last, since 2010.
Yeah.
All board meeting packets and.
So, yeah. So anyway, if we make that change, it doesn't mean, I mean, it will change things, it will make it harder. But Mandy, you're probably familiar with all the, you know, relevant laws and things, but it'll make it a little, maybe, well, you'll just have to figure some things out, which maybe you've already figured out, but anyway.
Dust off for red, like,
Just wondering if I could.
Please.
Just a couple of comments from me, and then if you're open to it, maybe invite the admin team that did speak to if they have opinions or comments, but just a couple pieces, totally sensitive fact. I was here when Paul was CEO and that transparency piece, so it is a bit sensitive on that because I don't want it to look as, you know, new CEO taking away that piece, but balance with, I do see the risks and involved, and I'm going through them. And it's personal, it's emotional. Things have come because of them that are awesome. I've even had people in the community come to my door. So the role of CEO, it becomes very personal in a small community. So just keep that consideration. Not to say not to do this, because I won't give my opinion, but I know there are significant risks here, and my work is to protect the organization the most, not my own personal opinion. So I think that kind of describes it.
But you know, for me at least, bring clarity to what you just said.
Yeah.
The way you used the words, I don't even know which side you're on.
Look, as I heard what you're saying is, this would be a board decision.
Yes. Yes. Very much a board decision.
I feel like it has been.
The transparency of it does have, at times have negative impacts that usually end up pointing at this, you know. And then, but not to say, I don't think this is, I think that the risks are out there are huge and they are brutal. I'd rather run two people and talk about whatever than the onslaught of years and years of litigation. And as well. Did that help?
Yeah, I think so.
Totally bored.
That did a good job. Oh, no.
ask just here, does that mean that this is a decision that we need to, or is this a decision we could make tonight?
I think it's a decision we could make tonight. I'm gonna lean towards it, but again, the board of five, so we will soon know what we're gonna do. I would welcome feedback from anyone here that wants to offer perspectives.
I see what he's going through and it really also the have that ability to everybody with something. With any joy, not others. That's what he's doing.
Us two organizations, I worked at have had multi-million-dollar settlements due to this type of situation where people, it's their career finding things that are said, things that are misconstrued, finding a loophole and winning. Not even seven for millions. Because the
risk of litigation is too great.
Absolutely.
Yeah.
So with that experience, I would very much lean towards and personally support limiting out there those bad actors.
I just have one ask to consider, I guess, if we make this motion. Since we did recently adopt a public records fee schedule, maybe we could do something about how this, if people request, a packet or something. That's not, it does say that we can waive like minimal fees, but I think that would be the having there. So we're not having the front desk, collect 5 cents for the packet to go to. Because
Why don't we just do it digitally?
there's still a fee for that.
I could claim.
Every 4 records that are digital, it's 5 cents. But even though it's minimal, I think that would be nice if you do make this motion to maybe just go ahead.
The packet is exempt from
Like,
the,
yeah, the monthly packet. I mean, right now we have the person that's looking for the last 16. So that's a little bit different. But
very good point. Motion? If people feel they've discussed it to death, I'm welcome to it.
Yeah. I make a motion that we continue to present it, but not report it.
So we would not have you run you to. And not publish the packet, like, if we, yes. So we will publish the minutes and the agenda. Packet would only be available at the door or meeting, or somebody through public records or whatever could request it digitally from the. That match up with Craig question? Okay. And Zoom would only be Zoom live, there'd be no Zoom recording. Well, we have a motion from Bob that's very. Somebody knows what it is, and so.
Requesting the clause about it being exempt from the records fee is not included in that motion.
Unless.
Well, I can just add the phrase and that anybody requesting a digital packet for the current month be exempt from any fee. Normally required for public records. Just make it the current month so they can't, if they go historical, they can normal public records.
First, do we finish first?
Only Bob can tell us if he
Yeah, I would
put a fence around it.
not recording, but we're gonna show it live. And as part of the packet. And then we could show up into it.
Which nights?
I think, to me, if we pass this before the end of the meeting, then we would not put tonight's meeting on YouTube, if that's what you're asking.
Although tonight's is elected because we made it.
Yes, but we wouldn't put it on YouTube, it'd still be available as a public record, but this is the last video public record we would have in these meetings. People have to attend in person. Anybody that attends in person can record their own.
Would we not put this one on there? Cause I feel like this is an important thing for people to see how we, if go through this, I think it's important for people to, or interested, I don't know. Proving it, I'm sure, but if someone was so inclined to see why, how, the why.
So then we should give it an effective date, because normally a motion takes, as soon as we vote and we approve it, that's the new rule, unless we.
What are your thoughts about that?
The intention, go ahead.
No, I just was one clarification about what again? Sorry, I had trouble following.
So whether tonight's meeting would be published with, if we decided we're not going to be publishing recordings anymore.
I mean, my position is, just publish it. I mean, it's one other meeting. Now, I know we don't like it, but why quibble over one meeting? The policy that was in place when the meeting started was it's going to be published. So I would just say publish this and let's start it next month. I mean, that would be mine.
My concern is that it still could be used against us, that some flaw in what we're doing could be. I don't know. I just, again, I don't want to make it any easier for anyone, because again, I feel most people that use this are doing it for the wrong reasons.
I worry that it counts as retroactive law. That basically we're changing the rules in the middle of the game. We've already recorded it. When we started the recording, the position was it was going to be published. There may be someone, I mean, it's unlikely, but someone who expected to see it and didn't come. And then we can't then say, well, we changed the rules during the meeting and it didn't see.
I also feel like based on the attendance of last meeting, very well attended, this meeting less so, there might be people at home who are looking for an update on the policy, who will be looking forward to seeing that. On the. Here's policy. Might be sad to not see that.
So I would add the clause like effective August 26th or something like that.
So that's my motion.
So that we would show tonight's meeting and then going forward, people can see why the change is going forward. Unfortunately, Matt made a good point, which is huge.
Which is not-
complimented his point, which is double irritating. That's on the record. We have a motion. You good with your motion?
I'm good.
I heard a second over here. You still good with the second?
Yes, I'll do a second.
Okay.
The only thing I'll mention during this, before we take the vote, is that because I'm sort of torn on this, I'm not going to get in the way of this, but I will likely abstain and be fine. I understand all the reasons and I appreciate the policies and I'm fine with it, but because I'm torn, I'm not going to get in the way of it. I will probably just abstain. It will also make things a little more interesting. We're always unanimous on it.
I asked a question, how many times, can we see how many times like staff members view this? I mean, staff rely on these recordings.
I don't say staff meetings, yeah.
Okay.
Sometimes, like I've heard from staff before, the days. Some staff have logged in to watch that. Yeah,
It's something controversial.
this is why this is particularly painful for you, that being forced into this discussion even. And making and voting on this, because it doesn't feel good at all. And I vacillate between also abstaining or. This is one of the worries.
Yeah, it's an ocean of this. To have people out there and. Like, yeah.
I would add to, there's a big push for. What's it called? Sorry. Class action lawsuits going on for hospitals in Washington, so. You know, we that have, or that have class action lawsuits going on right now. I know one of them for $7 million. I know one that they're very small compared to us that is looking at $1 million settlement. Is these organizations really getting? For how many dollars for what those?
What was the reason?
These ones were around 80. I think 10 minutes for this.
it is a tough one because again, I think everyone on this board really supports transparency. And certainly for the community who are impacted by this institution. But I think in today's world, we just have to accept there's a lot of negative reasons. People that utilize this not for the good of the hospital, but for the good of themselves, the detriment of the hospital. So let's go ahead and take a vote on it. I know it sucks, but it's got to be done. So what I'm looking for is we have a motion, we have a second, we've had a discussion.
What was the second?
Terry was the second. All in favor of supporting this motion, say aye.
Originally, aye.
I too will vote aye. Anyone opposed? Did you vote aye or did you?
I did not vote aye.
Abstentions.
I'm abstaining.
Abstaining.
Thank you.
Okay. So we have 4 in favor, 0 against, 1 abstention. That motion passes. So starting August 1st, we will no longer record or publish these meetings on YouTube. We will not disseminate a digital copy of the agenda online unless somebody requests it and we have a waiver for the month the agenda is relevant for. They're going to pay in fees for that. Match what we've heard from all of us. All right, any other new business that we'd like to talk about? Okay, thank you for, that's the sort of discussion Wisha was talking about. Get it in a one where we're not all in agreement, but we work through it. It's very healthy. So we're going to, did you have some comment?
No, no, not because of our board, but the section is just
Yep.
not. feel good.
Well, the world is very frustrated. So, it is 8:05, so we take a 5-minute break and then we'll, reconvene an executive session. How long, who needs time in executive session? Who do you need?
20 minutes, 10 minutes just with Janelle and Holly. 10 minutes. Yeah, I think just probably 15 minutes. With Janelle and Holly.
So how many total for you?
15 minutes.
15, all right.
I need 20.
And then the board needs 20 and Janelle will stay with the board for that 20 for our section here. So far I got 35 minutes. So we'll reconvene in 4 minutes from now at 8:10. And we will go for 35 minutes in executive session.
RCW.
So we are recessing an executive session to evaluate the qualifications of the applicant for public employment under RCW 42.30.110 subsection 1 subsection G. No action is anticipated at the end of it. We'll just reconvene the public before we adjourn. So,
KVH board signing off for the last time.
thank you everyone for attending.